it is. But everybody's participation is very important in this regard. So I congratulate especially the entire team of AOI, Telangana State, especially the Ramesh in this angle, and also Sriharsha and all the people who are all involved. I don't have an idea who are the judges here, but however, all the judges also, I congratulate them. And also at the same time, I wish all the participants to future also keep doing this thing. So unless otherwise, you present yourself at the regularly in this sort of meetings and all. So that will help you in future in all the records. And once again, I welcome all of them and also wish them all the success and do best and look forward. Thank you very much.
Thank you, sir. Dr. Naridsen. I welcome our organizing secretary of AOI TGCON 2025, Dr. Bhupender Rathod, sir. Give your message, sir.
Good afternoon, everyone. Respected Dwarkanath Reddy sir, respected Anand sir, the chairman of this conference, our Dr. Ramesh Yangan Dynamic, who is looking after the scientific session, and Dr. Sriharsha. First of all, a very good afternoon to you all, and all the PGs who are taking part in this case series presentation. Promise you that this virtual conference or virtual presentations will be completely unbiased and it will be totally transparent, and all the judges who are here, they are not related to our conference, or they are from some different places. They don't know anyone from this PGs. So once again, I congratulate for all for you participating in this conference and wish you all the success. Thank you, Dr. Ramesh.
Thank you, sir. Now I welcome Dr. Anand Acharya, sir, organizing chairman and secretary of AOI Telangana State Branch. Sir, are you there? Sir is trying to join. We will wait for sir. Meanwhile, I am thanking Sahasra ENT Foundation, Dr. Sriharsha, for arranging this virtual sessions. Every time since COVID 2020, we are organizing the virtual PG presentations with the support of Sahasra ENT Foundation. Thank you, Sriharsha, for your support and coordination. And before before going to the session, I request Sriharsha to give some technical guidelines. Meanwhile, I will give the original paper guidelines. This is the case series, Dr. Dwarkanath Reddy case series for postgraduates for best case series presentation. This case series has a time limit of 8 minutes only. I request all the participants to bound to the time limit. At least they have to finish within the 7 minutes. Give 1 minute time for the question answers so that you can get good mark. Earlier, we have conducted some orientation sessions to understand the presentations in the online platform. I hope everybody will get through the presentation. With the help of that presentation, I think everybody improves their presentation in this session. So in this session, we will scrutinize all the postgraduates to best 10 papers. In this case series, however, almost 30 papers they are presenting today with the support of the judges from all over the country. Various medical college HODs are going to be judges in this session. For this session, the two judges, Dr. Anil Kumar sir from Bangalore, Dr. Sharavanan sir from Chennai, Madras Medical College, are going to be the judges. Dr. Sagar will or Sriharsha will introduce the judges.
Good afternoon, sir.
All the very best. All the presenters are the winners. In this, the way of presentation is the important point rather than getting the medal. The presenting itself is the winning the medal. For the namesake, we will select the best papers. They have to present in the conference venue. All the very best presenters. I welcome Anand Acharya sir if the joins. Otherwise, meanwhile, Sriharsha will give some technical guidelines. But by 1:15, all the judges will join, will start.
Sir, can you hear me?
Sriharsha, please go ahead.
Am I audible?
Yes, Harsha.
Yeah. So thank you. I thank all the organizing committee, AOI Telangana 2025 being organized by Gandhi Medical College and team for giving again this year the opportunity to host this virtual case presentations. So regarding the orientation session we have done 2 days ago, and I hope all the participants have taken note all the tips and presentations. Few tips from my side is I request everyone to be seated in a well lighted area without any noise, and the sequence list has been already been shared in the groups, and make sure you are logged in and your presentation is ready, and just click share screen as soon as your preceding presenter is finished his presentation. And please be on time, restrict yourself, put a timer, and be on time, and whoever is sharing their screen, I request others not to share the screen when the other presentation is going. It will cause disturbance to them. And one more thing, make sure your dress layout and wear a good apron, and your turn on your video when your presentation is going on. Any other technical issues, even if you have, don't worry, we will guide you. Even if you are having any issues, with the permission of the chairman, you can present at the end if the issue is really genuine. Okay, thank you, sir. And Ananda Acharya sir has joined. I request him.
Yeah, welcome Dr. Ananda Acharya sir, organizing chairman of the conference and Honorary Secretary of AOI Telangana State. So welcome, sir. Please give your valuable message. Anand sir, please unmute and talk, sir. Anand sir.
Yes. Good afternoon, Dr. Ramesh and Dr. Sriharsha. Thank you for organizing this online presentation of the PG presentations for our forthcoming AOI state conference. And all the tips for a nice presentation has been given by Dr. Sriharsha. I thank him for that. Then I wish all the candidates all the best for your presentations. And continue, Dr. Ramesh.
Thank you, sir. For this session, I welcome Dr. M. Sagar and Dr. Revati from Gandhi Medical College to moderate this session, entire session, to call down all the candidates by serial number and supporting the judges. So I request Sahasra ENT Foundation Sriharsha, please show the judges details, sir. Their CV. We want to disclose the CV of the judges. Sriharsha. Dr. Sagar and Dr. Revati, please take over and welcome the judges and start the session as per the schedule. This is for 8-minute session. I request you to give warning bell at after 7 minutes, and after 8 minutes, final ring. After 8 minutes, no questions allowed for the candidates. If they finish within the time limit of 7 to 8 minutes, only they will take the questions.
Okay, sir. Okay, sir.
I welcome Anil Kumar, sir. Sagar, please take
Good
over.
afternoon, sir.
Please
Yes,
read
sir.
out the.
Okay. Thank you, sir. Good afternoon, everyone. I welcome Dr. Anikumar sir for the session, for judging the session, and a small CV about sir. Sir is a professor, Department of ENT, Bangalore Medical College and Research Institute, Bangalore, Karnataka. And sir has done his MBBS from Sri Devaraj Medical College, Bangalore, 1994, and MSc ENT from Father Muller Medical College, Rajiv Gandhi, in 2007. And sir has done his rhinoplasty fellowship at Shimian Rhinoplasty Clinic, Seoul, South Korea. And Sir has total professional experience of 25 years and total teaching experience of 16 years. And Sir is a UG MBBS teacher since 2008 and PG teacher since 2008 and thesis guide for MSc ENT. And Sir has been an examiner for a postgraduate and undergraduate for many years. And Sir has a lot of publications, and he is a member in professional societies like life member of local, state, and National Association of Otolaryngology of India, executive member of Bangalore IMA branch, and have served local association of Otolaryngology of India, Bangalore, as the executive member and treasurer. We welcome you, sir. And
Thank you, sir. Thank you.
Next, Dr. Sharavana Selvan, sir.
So we welcome Dr. V. Saravanan Selvan, sir, who is presently associate professor at Madras Medical College and graduated with MSc ENT from Madras Medical College. And sir has done his MBBS from Government Tirunelveli Medical College with a experience of 14 years. And sir is trained in endoscopic ear surgery, skull-base surgery, voice and head and neck surgery. And sir is a member of AOI and TNAOI. And sir has publications in reputed journals, and he's a editorial board member in TNAOI journal. And sir has a lot of presentations, and so we welcome you, sir, as a judge for this session. So can we start the first?
First 15 members, 1 to 15 member serial number judged by this set of judges. You can start with the
first.
Sir, Anand sir, Sharvan sir. Just wait for 1 minute. Sir is on the way.
Okay, sir. Okay, sir. Okay, sir. Meanwhile, Dr. Sushmita Chan.
Keep the candidate ready and ask them to share their screen.
Okay, sir. Meanwhile, Dr. Sushmita Chan, kindly share your screen and keep it ready.
Yeah, Sharvan sir is there. Welcome, Sharvan Selvan, sir. We are starting the session, sir. Nice, sir. With the permission of the judges, we are starting the session, sir.
Okay, sir.
Yeah.
Okay, sir. Sir, so Dr. M. Sushmita Chan, kindly share your presentation. Dr. Sushmita Chan, are you there? Okay, shall we go for the second number, sir? Meanwhile, the first.
Yes.
Dr. Likita, are you there? Can you reply? Dr. Likita?
Yes, sir.
Kindly share your screen. You have 8 minutes.
Yes, sir.
If you are ready, we'll start it. Okay, are you ready? Can we start the timer?
Yes, sir.
Sir, with the permission of the judges, can we start, sir?
Yes, sir. You can start.
Yes, sir, definitely.
Kindly start, Likita.
Yes, sir. Good afternoon, sirs. I'm Dr. Likita, and my topic is clinico-radiologic cytologic profile and management outcomes of thyroid swelling. Introduction. Thyroid disease is most common endocrine disorder. Thyroid swelling is a problem of extensive magnitude all over the world. In India, about 170 million people suffer from thyroid disease. The world's biggest goiter belt is the Himalayan goiter belt. Normally, thyroid gland is not palpable. In thyroid diseases, there will be swelling of thyroid gland and it causes symptoms on and esophagus as cosmetic deformity also. Thyroid swelling can be benign or malignant. Thyroid diseases include hyperthyroidism, hypothyroidism, nodular abnormalities like diffuse goiter, multinodal goiter, and tumors which include adenoma, papillary carcinoma, follicular carcinoma, medullary carcinoma, etc. Diagnostic modalities for thyroid swelling include history, clinical examination, blood test, radiological findings, surgical investigations, examination. Blood tests include thyroid function test, that is T3, T4, TSH levels, and calcitonin level in case of medullary carcinoma of thyroid. Ultrasound is a cost-effective investigation of choice, determining the extent of thyroid nodule. It helps to differentiate between benign and malignant nodules. It is the gold standard for reporting the thyroid nodule on USG. It helps for directing about the FNS ultrasound for follow-up of suspicion nodules and when to leave the nodule that are benign and suspicious. FNSC is a most sensitive, rapid, safe, and precise diagnostic tool. It plays a crucial role in diagnosing neoplastic conditions, inflammatory, and infective condition. The Bethesda system, which is widely accepted, was framed for reporting thyroid cytopathology. The aim of the study is to find out the relative occurrence of various pathological conditions presenting as thyroid swelling, describing clinico-radiologic, cytologic profile, and outcomes. Estimate benign versus malignant proportions, assessing FNSC versus final histopathology. Material and methods entitled on clinico-pathological and radiological study of thyroid swelling is a prospective study which is carried out in our ENT department. Sample size 25 patients with thyroid neck swelling was taken for study. Informed consent was taken from all patients. In criteria, all the patients coming to the ENT OPD swelling, FNSC was done. Age of the patient should be between 15 to 70 years. Of sex was taken. Inclusion criteria with other benign and later. According to the proforma, detailed history was taken regarding the name, age, sex, occupation, residential address, chief complaint, history of presenting illness, features and hypothyroidism, history of medical treatment of thyroid diseases, history of drug intake, and history of previous surgeries or irradiation of neck was recorded. After complete history and physical examination, a provisional diagnosis was made. Patients are subjected to investigations, laboratory investigations, complete thyroid profile, USG of neck with thyroid, FNSC with the Bethesda classification, histopathology. And the results were total 25 patients, age between 18 to 72. The mean age were 42. Predominantly female patients were seen, 19 female patients were seen, and males were 6. Peak in third to all the 25 patients have neck swellings. Pressure symptoms, dysphagia and dyspnea were seen in 7 patients. Pain or tenderness were seen in 4 patients. And the median duration of every symptoms were 8 months. Laboratory investigations, a routine pre-op lab, that is CBP, RFT, LFT, are normal in all the patients. Thyroid function tests were done in all 25. Euthyroid state was seen in 21 patients. Hypothyroid was seen in 3 patients. Hyperthyroid was seen in 1 patient. And anti-TPO antibodies were tested in 5 suspected thyroid cases. And 1 came out positive, that is Hashimoto's thyroiditis. Serum calcium were normal in all the patients. On ultrasound, solitary thyroid nodule was seen in 12 patients, multinodular goiter was seen in 9 patients, and diffuse thyroiditis pattern was seen in 4 patients. Suspicious USG features, that are irregular margins, microcalcifications, taller than wide, were seen in 6 patients. And FNSC Bethesda distribution. Bethesda 2, benign, was seen in 15 patients. Bethesda 3 was seen in 3 patients. Bethesda 4 was seen in 3 patients. 5 were seen in 2 patients. And malignant Bethesda 6 was seen in 2 patients. And the surgical management was hemithyroidectomy, lobectomy with mastectomy were done in 14 patients and total thyroidectomy were done in 11 patients. The final histopathology shows clinical or colloid or multinodular goiter were seen in 12 patients. Follicular adenoma were seen in 6 patients. Hashimoto's thyroiditis were seen in 2 patients. Papillary carcinoma was seen in 4 patients and follicular carcinoma was seen in 1 patient. Benign versus malignant. Among 25 patients, 18 patients were benign and the remaining 7 were malignant. FNSC versus HPE correlation. Considering the definitive FNSC category, that is only Bethesda 2, 5 and 6. Among the 19 patients, 17 were concordant. That is FNSC diagnosis agreed with HPE. And among the 19, 2 were discordant. That is 1 patient with Bethesda 5, but HPE turned out to be benign. 1 patient was Bethesda 2, benign, but turned out to be malignant. And intermediate category, that is Bethesda 3 and 6. Among the 6 patients, 3 turned out to be malignant on HPE. Post-operative outcome and complications. Uneventful recovery in most of the patients. Transient hypocalcemia was seen in 2 patients. Transient RLN palsy was seen in 1 patient. Wound infection was not seen in any patient. Hematoma was seen in 2 and mortality was seen in none. Discussion. The present study was undertaken to analyze the clinical representation of thyroid swelling and to study the proposition of versus malignant lesion, correlating clinical, cytological, and histopathological findings. The majority of the cases were benign, with a malignancy observed in small portions. Female patients constitute the predominant group, with female-male ratio 3.2.
Excuse me, Nikita, time is over. Your 8 minutes has been completed. Okay.
Sir.
With the permission of the judges, can I call next presenter, sir?
Yes, sir. You can call, sir.
Dr. Ashia Khatun. She will be presenting application of platelet-rich fibrin for the repair of less than 0.5 mm tympanic membrane central perforation, an alternative to meningioplasty. Can you share your screen, Dr. Ashia? Dr. Ashia, are you there? Dr. Ashia? Okay, sir, Dr. Akila? Tota Akila?
Yes, sir.
Okay, sir, with the permission of the judges, Dr. Tota Akila will present, sir.
Okay.
So she will be presenting unmasking the imposters, diagnostic dilemmas in head and neck lymphomas. Can you share your screen? At
Yes, sir.
7 minutes, you will have a warning bell, and 8 minutes, the presentation will stop.
Good afternoon, everyone. Today I'm going to present a case series titled Unmasking the Imposters, Diagnostic Dilemmas in Head and Neck Lymphomas. Introduction. Lymphomas constitute a diverse group of hematolymphoid malignancies broadly divided into Hodgkin's lymphoma and non-Hodgkin's lymphoma. Hodgkin's lymphoma is more frequent in head and neck region. Lymphomas, especially in head and neck region, present a diagnostic challenge due to their overlap with other neoplastic and inflammatory conditions. Aim to present a case series of head and neck lymphomas, emphasizing the diagnostic difficulties encountered. Materials and method. 4 patients aged between 40 and 80 years who presented with the varied clinical manifestations and overlapping features with other neoplastic and inflammatory conditions. Case 1. A 39-year-old male patient came to the OPD with the complaints of right side nasal obstruction since 10 days, swelling over the right cheek and right orbital area since 1 week. History of nasal discharge is present, mucopurulent in nature, occasionally bloodstained. History of headache, chest pain, pain over the orbital area is also present. Patient is a known case of diabetes. On examination, in direct nasal-scopic examination, pinkish growth noted in the right middle meatus area with mucopurulent discharge. Swab was taken from the middle meatus area and sent for fungal culture, which was negative for fungal elements. Patient was subjected to FES and right orbital decompression under GA. Pinkish mass visualized in the right maxillary sinus. Biopsy was taken from the mass and sent for histopathological examination, which was suggestive of NK T cell lymphoma, positive for CD45, CD3, CD56, and CD30 immunomarkers. Patient was sent to MNJ Cancer Hospital for further management. Initial clinical presentations were directing us towards the acute invasive fungal sinusitis, but after the evaluation, the diagnosis came as to be lymphoma. Case 2, a 43-year-old female patient came to the OPD with the complaints of orbital swelling on the left side since 1 month, associated with severe pain since 1 month. History of headache, pain over the right cheek was present. Patient underwent PES under GA at some other hospital 6 months back in view of fungal sinusitis. History of COVID infection was present and was known case of diabetes. On examination, post a direct nasal endoscopic examination, post-FES status was noted. Left maxillary sinus and ethmoidal sinuses were patent. Polypoidal tissue was noted in maxillary sinus with lamina papyracea was eroded. CT scan was the below CT film shows soft tissue densities in left maxillary and ethmoid sinuses. Sphenoid sinus noted extending into the orbit along with the medial compartment.
Dr. Akila, you have to show your face.
Okay, so 1 second.
Someone paused the timer also. Please check the timer, please.
I'm checking here, sir. No problem. I have another time. Stop.
The below CT scan is showing soft tissue density in left maxillary sinus involving the frontal and sphenoid, with the soft tissue in the orbital area along the medial compartment, displacing the eyeball anterolaterally and superiorly. Management, biopsy was taken from the soft tissue in the left orbit. Histopathological examination was suggestive of inflammatory status. Negative for fungal elements. Bone marrow biopsy was done and it was suggestive of diffuse large B-cell lymphoma. Patient was referred to MNJ and started on chemotherapy. Again, the patient complaints were directing us towards the acute invasive fungal sinusitis or maybe recurrent, as patient already underwent treatment for fungusy invasive sinusitis, but on evaluation it came as to be lymphoma. Case 3, a 79-year-old male patient came to the OPD with the complaints of swelling over left orbital area since 3 months, associated with severe pain and headache. History of bleeding from nose was present. No history of nasal obstruction. Proptosis was present on the left side. Eyeball is pushed outward and laterally. On direct nasal endoscopic examination, nasal cavity was normal with mucoid discharge in the middle meatus. CT scan was suggestive of soft tissue density in left maxillary sinus, extending to left orbital area with erosion of floor of the orbit, pushing the eyeball laterally and superiorly, with level 1B, 2, and 3 lymph nodes were present. Patient was subjected to FES under GA. On examination, pale mass was noted in the left maxillary sinus. Here in the video, we can see biopsy was taken from the mass and histopathological examination was suggestive of poorly differentiated malignancy, query lymphoma or query poorly differentiated carcinoma. Bone marrow biopsy was done, which was suggestive of diffuse large B-cell lymphoma, positive for CD20, CD79A, and CD45. Patient was referred to MNJ for further management. Here, patient's clinical symptoms were directing us to sinonasal malignancy, some carcinoma of the maxillary sinus or maxilla, but it turned to be lymphoma. Case 4, a 65-year-old male patient came to the OPD with the complaints of swelling over soft palate since 4 months, difficulty in swallowing since 3 months, difficulty in breathing since 1 week. On examination, oral cavity examination, in the below picture, we can see pinkish smooth mass noted over the soft palate, obscuring the entire oropharynx. Posterior pharyngeal wall was not visualized. Level 2, 3 lymph nodes were palpable on the left side. On direct nasal endoscopic vision, pinkish mass was visualized in the nasopharynx, covering the entire nasopharynx, likely arising from the soft palate. Here in the CT scan, we can see a homogeneous mass in the oral cavity, likely arising from the soft palate, extending into the nasopharynx and posteriorly abducting the pharyngeal wall. FNAC was done from the cervical lymph node, suggestive of mantle cell lymphoma. Bone marrow biopsy aspiration was suggestive of non-Hodgkin's lymphoma. IHC markers were positive for CD5, CD25, BCL2, and high. PET scan was showing metabolically active enhancing soft tissue in the posterior aspect of the oral cavity and over the soft palate. Treatment, because airway was completely obscured, patient was subjected to emergency tracheostomy to secure the airway. Patient was started on chemotherapy, injection cyclophosphamide for 500 mg. 2 cycles were finished. Image is showing this image is showing after 1 cycle of chemotherapy. Here we can differentiate the structures like soft palate and uvula, likely showing the growth is arising from the left side of the soft palate. This is the video after second cycle of chemotherapy. Complete swelling was disappeared. Again, this case, it presents as a mass over the soft palate. Usually, lymphomas in oral cavity or oropharynx arise from the Valde's ring, but this is arising from the soft palate. Conclusion: head and neck region is a common site for initial presentation, particularly for non-Hodgkin's lymphoma. Cervical lymphadenopathy is the most frequent manifestation, followed by extranodal disease involving Valde's ring, nasal cavity, paranasal sinuses, salivary glands, and thyroid gland. Chemotherapy and drug regimens. Mainstay of treatment for lymphomas is systemic chemotherapy, sometimes combined with immunotherapy. In selected cases, radiotherapy is also given. For non-Hodgkin's lymphoma, ABVD regimen was given: adriamycin, doxorubicin, bleomycin, vinblastine, and dacarbazine. While for non-Hodgkin's lymphoma, which is common in head and neck region, CHOP regimen was used: cyclophosphamide, doxorubicin, vincristine, and prednisolone for aggressive B-cell lymphomas. Head and neck lymphomas poses unique diagnostic challenges due to its anatomical complexity and the wide range of pathologies that can present with overlapping clinical features. Advances in chemotherapy regimens coupled with the target biological therapies have markedly improved the survival outcomes. This case series underscores the importance of considering lymphoma and differential diagnosis of atypical head and neck masses. These are some of my references. Thank you.
Any questions from the judges, sir?
First case, you have told that you have referred the case for further management. What was the further management?
To start on chemotherapy, sir.
Is there any protocol for these cases, depending on the stages? Okay, continue. Thank you.
Sir, any other questions, sir?
No,
Okay,
sir, no, sir.
sir.
Next person.
Next presenter, serial number 5, Kasham Vasavi. Are you ready with your presentation? Dr. Vasavi, are you ready with your presentation? Okay, so we will go to next presenter, serial number 6, Dr. Sana Fatima. Dr.
Yes,
Sana
sir,
Fatima, are you ready with your presentation?
Unmute button. Sir, I'm available, Vasa.
Okay. Sir, serial number 5, sir, Dr. Kasham Vasavi.
Okay.
Start your presentation. Next presenter, kindly be ready.
Good afternoon, everyone. This is Vasavi. Today's my topic is a correlation between high resolution computed tomography, temporal bone findings, and intraoperative findings in chronic suppurative otitis media. WHO observed an overall CSOM prevalence of 7.8% in Indian population. CSOM is the inflammation of middle ear mucosa for a duration of more than 2 weeks that results in ear discharge. It is associated with hearing loss. CSOM is associated with the significant morbidity, thus posing a 1/3 of the CSOM have been associated with polysteatoma. The temporal bone accommodates vital structures like internal carotid artery, facial nerve, jugular bulb, sigmoid sinus. These structures have anatomical variations which makes it difficult at times. Early identification is needed to adopt the appropriate surgical procedure and to prevent hearing loss and its complications. The aim and objectives of this paper is to correlate CT findings with intraoperative findings of CSOM to assess the role of preoperative high resolution CT temporal bone in assessing extent of CSOM and complications associated with it. The materials and methods used in this is a hospital-based prospective study done in 63 patients attending OPD in SVS Medical College. Preoperative examination of the patient, including complete clinical history, otoscopic examination, and pure-tone audiometry was done. HRCT of temporal was taken in 1 mm sections in axial and coronal pin preoperatively and compared with intraoperative findings by doing either cortical mastoidectomy or cortical mastoidectomy. The result after observing is like by taking 63 patients, out of which 39 were females and 24 were males. And out of 63 patients, 29 has left ear disease and 34 has right ear disease. So as per the middle ear soft tissue or cholesteatoma, if you find out of 63 patients, the HRCT in HRCT it is present in 19%, and intraoperatively also it is present in 4%. If it is absent in 44 members, and intraoperatively also it's absent in 41 members. As per EAC soft tissue or granulation, in HRCT, if it is present in six members, intraoperatively also we found that EAC tissue or granulation is present in 4. If it is absent in 57, intraoperatively also almost equal, 56, it's absent, this finding, which shows almost similar as per the ESC polyp, if we find in HRCT, if it is present in 6 members, and intraoperatively also it is present in 6 members, and if it is absent in 57 in HRCT, in intraoperatively also there is no ESC polyp in 56 members. As per malleus erosion, if we find if it is present in 21 members in HRCT, intraoperatively also there is malleus erosion in 19 members. If it is malleus is normal in 42 in HRCT, intraoperatively also it is normal in 37 members out of 63. As per incus erosion, if it is present in 15 members, intraoperatively also 12 members we find incus erosion is present. Incus is normal in 48 members in HRCT findings. In intraoperatively also in 47 members we found that there is no incus erosion. As per stapes erosion, if it is present in 8 members, intraoperatively also we found that there is stapes erosion is 4%, which is like almost half. And if the stapes is normal in 55% in HRCT finding, and intraoperatively also we found that there is 52% the stapes is normal. As per mastoid antrum cholesteatoma, in HRCT finding, if we found that there is present in 7 members, and intraoperatively also 7 members we found that there is mastoid antrum cholesteatoma. If it is absent in 56 and intraoperatively there is no mastoid antrum cholesteatoma in 39 members. As per tegment plate erosion in HRCT, if it is present in 11 members, intraoperatively it is and if it is normal in 52 members, this tegment plate erosion in HRCT, and it is also seen in 49 members. As per the sinus dural angle erosion, if it is normal in 63 and intraoperatively also it is normal in 61. Only there is erosion present in only 2 members. In tympanic part of facial nerve dehiscence, if it is present as per the HRCT in 5 members, intraoperatively also we found there is dehiscence in 4 members. If it is normal in 58 and intraoperatively we found normal in 53 members. As per lateral semicircular canal erosion or fistula, if it is present in 9 members in HRCT findings, intraoperatively we found only in one member. If it is found normal in 54 members, this lateral semicircular canals, intraoperatively we found that is normal in 52 members. As per mastoid cell, if we found that it is mastoid cellularity is normal in 45 members in HRCT findings, intraoperatively also it is normal in 41 members. If it is sclerosed in 18 members, and but intraoperatively it is normal in 15 members. It is only present in 3 members. And complete result from these findings is the sensitivity and specificity and accuracy. EAC soft tissue sensitivity is 80%, specificity is 96%, and overall accuracy is 95% when we compare to the CT and intraoperative findings in CSOM. And middle ear malleus erosion, sensitivity is 79, specificity is 94%, overall accuracy is 88%. Middle ear incus erosion, sensitivity is 92%, specificity is 94%, and overall accuracy for this finding is 93%. And tegment plate erosion, sensitivity is 50%, and specificity is 85, and overall accuracy of this finding is 82%. Facial nerve tympanic part erosion, sensitivity is 44% and specificity is 98%, and overall accuracy is 90% of this finding in this study. And lateral semicircular erosion, sensitivity is 33%, specificity is 86, and overall accuracy is 84%. And these are the few HRCT and operative findings of cholesteatoma. First two pictures, and then facial canal dehiscence, segment plate erosion is seen in this, and then otomastoid is also seen. And the conclusion of this study is HRCT provides excellent information with reasonable accuracy in skilled hands. This helps alert the surgeon to anatomical variations prior to the surgery. Significant correlation is found in identifying EAC polyp, soft tissue or granulation, mastodontine cholesteatoma, ossicles erosion, tegment plate erosion, tympanic part of facial canal dehiscence in HRCT, and intraoperative findings. But correlation of middle soft tissue and lateral semicircular canal erosion has its own challenges. And these are my references.
Will you able to distinguish between cholesteatoma and mucosal disease
Yes, sir, mostly.
on CT?
Yes, sir.
Suppose if I am suspecting ossicular erosion, which will be the best? This one?
HRCT will be the best for ossicular erosion. Any kind of
Any other
anything
investigation?
related to the bone.
Are you sure?
Yes,
Are you
sir.
sure, or there
HRCT
is something
will be
else? Huh?
For ossicular erosion, we can do pure tone audiometry also.
Madam, investigation, we are talking about CT here, isn't it? What is cone
Yes,
beam
sir.
CT? Okay, thank you.
So, we are going for serial number 6. Dr. Sana, are you ready?
Hello. Yes, sir. Good morning, sir.
Kindly present.
Yes. Good morning, sir. Today my topic of presentation is evaluation of anatomical variations of sphenoid sinus, a computed tomography based study. Outline of this presentation. First, we'll go through introduction, aim, methodology, results, discussion, conclusion, and references. Introduction. Among all the paranasal sinuses, sphenoid sinus is surrounded by all vital structures. Function endoscopic sinus surgery is associated with dreadful complications. So, knowledge about the anatomy of sphenoid sinus and its variations can avoid the major complications of function endoscopic sinus surgery. So, CT scan has been routinely used as a part of initial workup for the patients undergoing tests. So, it will help surgeon to have adequate knowledge about the anatomy and to identify the limits during surgery. Aim to evaluate the prevalence of anatomical variations of the sphenoid sinus and its relations to the surrounding vital structures on the CT paranasal sinuses. It is a retrospective study, duration from the March 2024 to December 2024, 10 months duration. Total study population is 100 patients, and inclusion criteria, all patients undergoing function endoscopic sinus surgery. Exclusion, patient who has history of trauma or prior surgery of sphenoid sinus and the sinonasal tumors. These are excluded from our study. Methodology. So here, 100 CT scans of the paranasal sinuses were studied among patients who are about to undergo function endoscopic sinus surgery. So in the CTPNS, we took coronal, axial, and sagittal sections. And this, what we are assessing is anatomical variations of the sphenoid sinus and onodicel, types of pneumatization of the sinus and extension of pneumatizations, protrusion and dehiscence of internal carotid artery, onodicel, and attachment of intersphenoidal septum. So results in our study, out of 100 patients evaluated, there are 55 males and 45 females. Among all the 100 patients, sphenoid sinus has the maximum left dominance is 26% and right dominant sinus is 24%. Among degree of pneumatization of the sinus, cellular type was the most common type, that is 78%, and followed by precellular and concave. So there are various degrees of pneumatization of the sphenoid sinus. Concal is a small limitized space in front of anterior wall of the sella. And the sinus ends anteriorly to the anterior edge of sella is a presellar. Sella type is a posterior wall of sphenoid sinus between anterior and posterior wall of the sella. And posterior sella type is the sphenoid sinus located behind the posterior wall of sella. So these are the 4 types of sinuses, sphenoid sinus variations. Image A is showing concal type, B is showing presellar type, C is showing sellar, and D is showing posticellar. Anatomical variations. So these are the results what we found out up from our study. Pneumatization of anterior clinoid process is total 29%. Most common is the pneumatization of pterygoid process and Onodi cell variations. These are the most common findings. And rarest are the protrusion of maxillary and median nerve, lesions of internal carotid artery, and lesions of maxillary nerve. These are the less commonly seen. So images we can see. First image is bilateral pneumatization of pterygoid process. That is nothing but lateral recess, and right side sphenoid we can see the mediate canal which is protruded into the sphenoid sinus. Image B, you can see anterior clinoid process pneumatization via arrows, and inferiorly image is sphenoid sinus, intersphenoid septum is present, and the anterior clinoid process pneumatization. This is a left dominant sphenoid sinus with the intersphenoid septum goes and attaches to the optic nerve. So discussion, sellar is the most common type of sphenoid sinus pneumatization, which is 78%. And in our study, there is extent of sphenoid sinus pneumatization of anterior clinoid, pterygoid, and greater vein of sphenoid was 29, 33, and 7% respectively. And the attachment of intersphenoid septum is to internal carotid artery and to the optic nerve, 12 and 18% respectively. Discussion, lesions of internal carotid artery, optic nerve, maxillary nerve, median nerve is 3, 8, 3, and 4% respectively. Here the protrusion of internal carotid artery, optic nerve, maxillary nerve, median nerve is very less, 7%, 3 and 4% respectively. Pneumatization of Onodi cell is 31%. Conclusion, in our study, to minimize the complications of the neural and vascular structures around the sphenoid sinus during the surgery, so CT scans are essential for pre-surgical evaluation of patient undergoing functional endoscopic sinus surgery. References, so these are the references from which I studied my topic. Thank you, sir.
Dr. Fatima.
Who has proposed this classification? What's the name?
Yes, sir.
Who has proposed this classification? Sphenoidal sinuses, they have classified.
Yes.
By whom was it proposed? What is arrested pneumatization? Thank you.
Thank you, sir.
Serial number 7, Dr. Sankalp Gonkar. Are you there?
Yes, sir.
Kindly share your screen.
Am I audible, sir?
Yes, kindly start. Start your presentation.
Yes, sir. Good afternoon, everyone. My name is Dr. Sankal. Today I'm going to have a brief presentation on the outcomes of posterior cordectomy in the management of bilateral abductor palsy. Bilateral abductor palsy is a rare but serious condition wherein there is immobility of both the vocal cords, usually occurring secondary to iatrogenic trauma, commonly thyroid surgeries and other neck surgeries. Patients are known to present with severe inspiratory stridor. So one of the clinical challenges we often have is balancing the airway adequacy with the voice functioning. Now, tracheostomy has been a long-standing traditional solution in its management, but it comes with significant social, physical, and psychological burden. So to manage that, we have posterior cordectomy. It's a modern airway preserving option. Just first described by Dennis and Kashima, posterior cordectomy is a minimally invasive endoscopic procedure where we widen the airway by removing a part of the posterior vocal cord. The main aim is to restore the sufficient airway for breathing while minimizing voice and aspiration risk. My aim of the surgery was to evaluate the effectiveness of posterior cordectomy in the management of bilateral abductor palsy, focusing on airway adequacy and functional outcomes. Now, some of my objective was to assess the airway, determine decannulation rates, analyze voice outcomes, evaluate swallowing and aspiration risks, to document any complications and the surgical safety with regards to this procedure. That being said, I performed a retrospective analysis was conducted on 3 patients diagnosed with bilateral abductor palsy who underwent posterior cordectomy at our hospital between December 2024 to August 2025. The procedure was performed using coblation anesthesia, and the outcomes were assessed on voice quality, the airway and the airway frequency. It was good to know that none of the patients required any tracheostomy during the follow-up or post-surgery period. All the patients of who gave informed consent of all age groups and were included into the study. Their findings were confirmed by video laryngoscopy. It was noted that there was no malignancy or other glottic pathologies in these patients. All patients who are not willing for surgery with bleeding disorders, patients with malignancy or other glottic pathologies were ruled out. All 3 patients were primarily managed at our institution, and they all had history of iatrogenic trauma, namely thyroidectomy. They all presented in stridor, and an emergency tracheostomy was done. All the findings were confirmed on video laryngoscopy. As we can see, both the vocal cords of all the 3 patients have restricted mobility. Now, posterior cordectomy, was classified. Cordectomy, as I said before, was a minimally invasive procedure, which was further classified by the European Laryngological Society into total of 5 groups. There's also a 6th one that, based on the amount of layers which are excised, they are classified into subepithelial, subligamental, transmuscular, total cordectomy, and an extended cordectomy as well. That being said, the procedure which was adopted during posterior cordectomy is a type of total cordectomy wherein we excise all the 3 layers of the vocal cord along with some portion of the vocalis muscle. A transmuscular cordectomy was employed. The patient was explained the entire procedure. Orotracheal intubation was done, shifted to Boyce-Jackson's position. A suspension laryngoscope was used to expose the glottis. While the vocal cords were adequately identified, a coblation wand was used to excise the posterior segment of the vocal cord. Now we preferred the vocal cord with the least mobility was preferred. Following the procedure, hemostasis was achieved using suction cautery. The edges were inspected for any for any bleeding. In the post-op, recovery was uneventful. Extubation was done pretty quickly. Voice rest was advised. Patient was advised steroids and IV antibiotics, while follow-up was done for voice assessment and surveillance laryngoscopy. These are some of the intraoperative videos. As we can see here, the right vocal cord is being excised using the coblation wand. This is the post-operative appearance following posterior cordectomy. The results, all the patients showed increase in posterior glottic cap post-surgery. All the patients successfully underwent decannulation within 2 to 3 weeks. However, mild to moderate voice deterioration was observed, and there was minimal intraoperative bleeding which was noted. Post-operatively, both patients with the left vocal cord, as we've seen here, was excised. Pre-operative, post-operative, there was some phonetic loss noted. Discussion. Patients with bilateral vocal cord paralysis often present with significant airway compromise. However, their voice quality relatively remains unaffected. So our priority while their management was to provide comfortable breathing without incurring much loss in voice or swallowing function. Also, patients usually have a strong desire to avoid permanent tracheostomy, and they prefer going for an alternative route where complications can be avoided. That being said, coablation assisted posterior cordectomy provides a significant and effective alternative. The technology's ability to ablate tissues at low temperature following resection of the posterior cord helps prevent any sort of minimal thermal damage. Importantly, none of the patients in our cohort required any sort of tracheostomy following the coablation procedure. While the voice quality did slightly decline due to the posterior glottic inadequacy, however, patient retained functional speech. None of them developed any sort of aphonia. The trade-off which was between this improved airway patency and the voice changes was considered acceptable by most of the patients, especially in light of the significant improvement in breathing and activity tolerance. That being said, in conclusion, posterior cordectomy is an effective and safe procedure in the management of abductor palsy, offering significant airway improvement with voice preservation. There is a low complication rate associated with this procedure. However, a careful patient selection and preoperative counseling has to be done. It is required to refine our surgical skills, and further studies have to be conducted with larger cohorts and longer follow-ups to validate these findings. These are some of my references. Thank you.
Sir, any questions?
When do you think the normal mucosal wave pattern is restored?
Sir, can you repeat the question, sir?
When does the normal mucosal wave pattern, what is the time duration it is restored by?
Sorry, sir.
Okay, thank you.
Next serial number, Dr. Vishwajit. Are you there?
Yes, yes, sir, I am there.
Kindly share your screen.
Start my screen. Yes.
Yeah, share your screen and start.
Yes, sir. Can you see my first slide, sir?
Start.
Can I start, sir? Okay. Very good afternoon, respected judges, esteemed faculty and colleagues. So I am Dr. Vishwajit, and today I'm going to talk about a role of narrowband imaging in evaluation of laryngeal and hypopharyngeal lesions, a prospective study. So at the onset, let me just tell you why I'm doing this particular study. So we all know that head and neck malignancies dominate the landscape of malignancies in India, and especially in southern part of India, the number of cases is very overwhelming, and therefore early diagnosis and better management of these conditions is very important. And at a personal level, technology and larynx tend to fascinate me. So that is why one reason that I'm doing this particular study. I've done this particular study. So a little bit about narrowband imaging. Narrowband imaging is an optical enhancement technique that enhances the mucosal blood vessels. So it relies on the property of light, that is, the higher the wavelength, the deeper the light penetrates. So we all know that angiogenesis is a hallmark of tumor malignancies, and so narrowband imaging takes advantage of the physics of light and this particular property of malignancy, that is angiogenesis. And what we get it is a technology called narrowband imaging. Here you can see the blue light, which is of a wavelength of 450 nanometers, is absorbed by the vessels in the superficial layer in the mucosal surface, and the green light, which is a wavelength of 540 nanometers, is absorbed by the vessels in the deeper submucosal veins. And this gives us a contrast image wherein we can study the pattern very clearly. So NIA, in his initial study that was conducted in 2011, has given a classification when he has studied those patterns and given, and type 1 to 4 are considered benign, and type 5 are considered malignant. So as the tortuosity or the caliber of those vessels become varying, so you can classify them as benign or malignant. So the aim of the study is to assess the diagnostic value of narrowband imaging in characterizing the laryngeal lesions, with emphasis on the vascular pattern, that is ICPL loops, with histopathological findings. And also the objectives are to evaluate the diagnostic validity using sensitivity and specificity, and to assess the NBI role of NBI in guiding the site for biopsy during procedure. So it is a prospective study that I have studied over 30 patients. around a duration of 6 months using a study tool called Olympus Medical System. So this is an endoscopic system that we have at our place, and it has a narrowband imaging is a patented technology of Olympus. So once the detailed study was explained to the patients and their attenders, informed consent was obtained and relevant history was collected. And first, under 10% lignocaine spray, I performed video laryngoscopy, and then later in the same setting, the patient underwent narrowband imaging. So results in my study, I had around 24 females, 24 males and 6 females. Among the distribution of lesions, 80% of them turned out to be malignancies, and two pre-malignant lesions which were leukoplakias, and 3 benign lesions, one of them being a papilloma and the other 2 being a vascular polyp. So in the malignancies, I have observed like a type 5 pattern in around almost 25 malignancies, and all of the malignancies. In pre-malignant lesions like leukoplakia, I have observed type 3 pattern in 2 patients. And under benign, I had a vocal polyp in which I have observed a type 2 pattern. And in papilloma, I have observed a type 5 pattern. So this is what we get to see in a conventional white light video laryngoscopy. And on the use of narrowband image filter, you can see the extension, and you can clearly study these brown dots. And biopsy was guided with the use of NBI filter, and it came out to be a squamous cell carcinoma. Here you can see a fairly benign looking growth, and on the click of a button you get a narrowband filter, and we have observed a type 5 pattern, and what we got is a squamous cell carcinoma when we took a biopsy from this site. In papilloma, we have observed a type 5 pattern. This is the white light endoscopy, and this is the narrowband imaging. And in vocal polyp, there was no brown spots that were seen. It is a type 2 pattern, and it came as a vocal polyp. So when narrowband imaging was used in conjugation with white light endoscopy, there is a significant improvement in the sensitivity and specificity. So discussion. So early detection, narrowband imaging helps us in early detection of and recognizing the pre-malignant and early malignant lesions. It is a very practical tool. You can do it as a office-based procedure. There is no need for any dye or any. It's not an invasive procedure. And type 5 IPCL pattern has a very sensitive and is highly sensitive and selective, specific. And in cases where there is no like exophytic growth, this tool becomes especially useful. It is highly accurate. It can be used in identifying benign lesions also. So when I've compared my study with the similar studies that have been performed earlier, the findings were in line with all the other studies. So NBA comes with its own set of challenges, like the system being quite expensive, and there is a learning curve in like identifying the type 5 like the IPCL patterns. And pitfalls are like the type 5 pattern was seen in my study. It was seen in papillomas and also in malignancies, leading to a little bit of confusion. Limitations of my study is that it is a very small sample size. So as a conclusion, I would like to say that narrowband imaging along with white light endoscopy is a very good tool that we can use as a common diagnostic and follow-up in our day-to-day laryngology practice. These are my references. Thank you.
When you have compared all the studies, what is the accuracy which you have observed?
Sir, narrowband imaging was highly accurate, sir. It was around all the 100% cases that were given as malignancy in histopathology. I could see type 5 pattern in them.
No, when you compared with not your study, when you are compared with other studies, what is the
Yes,
accuracy in their studies, what they have given?
So I've taken as sensitivity and specificity also, sir. So this, like you can see this is a study that has been conducted in India, and it has showed a 100% sensitivity and specificity of 71%. But in my study, I got a specificity of 76%.
But overall accuracy, they are telling about 70%.
Yes, sir, around 70%. Because there are other pitfalls like type 5 pattern identification and learning curve associated.
Okay, thank you.
Yes. Can I stop sharing my screen, sir?
Yes. Next serial number 9, Dr. Aparna. Dr. Aparna, are you there? Dr. Aparna, are you there? Okay. The next serial number 10, Dr. K. Bhargavi. Dr. Bhargavi, are you there? Dr. Bhargavi. Okay, we will go to the
Hello,
next
sir.
serial number. Yeah. Who?
Hello, sir.
Okay. Is it
Sir,
up? Yeah. Okay.
am I
Dr. Bhargavi.
audible, sir?
Yes. Serial number 10, Dr. Bhargavi. Kindly share your screen.
Yes, sir.
Start when you're ready.
1 minute, sir.
Visible, Amma. You can start now.
Right. Sir. I'm ready, sir.
Start.
Good afternoon, everyone. My clinical study is on sinus polyposis and its management. Sinonasal polyposis is a chronic inflammatory disease of mucous membrane of the nose and paraganglioma sinuses. Prevalence is about 1 to 4% of the population. It appears as smooth gelatinous pedunculated round masses causing nasal obstruction. With increasing use of antibiotics, many fungi, both saprophytic and pathogenic fungi, are affecting the nose and paraganglioma sinuses. Fungi are found mainly in dust, air, soil, plants, and decaying organic matter. Fungi adhere to these particles and are inhaled, and thus they are deposited in the nose and paraganglioma sinuses. The role of fungi affecting nasal polyps is difficult to determine. Fungal elements were suspected to be the causative agent of chronic rhinosinusitis, and fungal etiology was found to underlie nasal polyps. Present study is to know the prevalence of the fungal infections in patients with sinonasal polyposis. Patients with anatomical abnormalities with the impaired drainage, such as nasal polyps, is fungal colonization is seen in these patients, and the chronic inflammatory states are also vulnerable to fungal colonization. Aim of the study is to determine the prevalence of fungal infections in patients with sinonasal polyposis and to evaluate the clinical presentation and management. Clinical study is conducted in patients attending with chief complaint of nasal polyps and nasal obstruction period from January 2024 to 2025 in the Department of ENT in SVS Medical College. 26 patients were taken into study. The polyp specimens were sent for direct microscopy and mycological culture, and the prevalence of fungal infection is this observed. First, the clinical examination followed by diagnostic nasal endoscopy was done, and all the cases were investigated with CBP, screening test, X-ray test, CT scan of nose and paraganglioma sinuses. Then the specimen which is taken is processed with direct microscopy by 10% KOH mouse and mycological culture with sabrotex agar at 25 and 37 degrees Celsius. Observation of growth was done periodically for 4 weeks. The presence of thread-like, branching-like structures like hyphae and the bead-like structures, that spores, if present, these are considered as a positive test, and the mutation is seen in the sabrotex agar medium. These are the various fungal cultures of nasal polyps in sabrotex agar and the pathology. Here we can see the fungal growths. Then all the cases are planned for functional endoscopic sinus surgery under general anesthesia. Fungal then taken was sent for microscopy, culture, and histopathology. Post-operatively, itraconazole is given in all cases where the fungal culture is positive. Topical and systemic steroids were given in follow-up patients. These are the various intro photos. And the results that we have seen is there is equal sex distribution, 13 males and 13 females, no gender predominance is seen. Age group mostly 21 to 30 years with mean age of 29% from poor socioeconomic background. And nasal obstruction is the most common symptom in all patients at the time of admission. Fungal culture findings, we have observed fungal infection in 17 out of 26 patients, most commonly being the Aspergillus species. Here we can see the age distribution, mostly in 21 to 30 years, and 10 patients of Aspergillus species and 6 of flavors, 1 of fumigators, and 2 patients, there is microscopy positive, but culture is negative, and 7 patients, both culture and microscopy is negative. 12 of our patients already gone through surgery in the past in the form of nasal polypectomy. This shows the reflective higher recurrence rate of the disease. In 19 patients, they presented with bilateral nasal polyps. In majority of the patients, more than one sinus was involved, sinus being the top, and in majority of the patients, more than one complaint was present. Poor living conditions, dampness, overcrowding, these all the risk factors observed. Increasing use of antibiotics, many fungi, both saprophytic and pathogenic fungi, are affecting the nose and paranasal sinuses. Clinical examination, diagnostic nasal endoscopy, and CT scan of the paranasal sinuses are important to know the extent of the polyps and for the management of the patient. In this study, Aspergillus species is the most common fungi observed. Direct microscopy with the 10% KH mounts and mycological culture with the saprotextros agar at 25 and 37 degrees Celsius is very important to isolate the causative fungi. Good prognosis is seen in post-operative itraconazole that is given in all patients where fungal culture is positive. And the topical and systemic steroids play an important role in the prevention of recurrence. These are all my references. Thank you.
You know, these chances of recurrence are more. So what do you use as a prognostic factor to tell the patient? Recurrence rate is more, isn't
Sir, if the fungal culture is positive, then the chances of recurrences are more. And that's what we have observed, sir. For bilateral polyps, ethmoidal
it?
polyps,
To
chance of
explain to the
recurrence is more.
patient, isn't it? So you should use CT grading. You can use. Okay, thank
Yes, sir. Okay.
Sir. Next presenter, serial number 11, Dr. Geetanjali. Are you there?
Yes, sir.
Kindly share your screen and present.
Good afternoon, one and all. I'm Dr. Geetanjali Joshi, second year PG resident from Osmania Medical College. And today my case series is when common symptoms.
Your screen is not visible, Amma.
1 second. Is it visible now, sir?
Yes. You can start.
Yeah. So my case series is when common symptoms hide the rare diagnosis, nasal masses across different age groups. So nasal mass is commonly present with the symptoms like obstruction or growth in the nasal cavity and discharge, often suggesting the benign causes. However, the rare pathologies may also mimic these common presentation, which will cause a delaying in diagnosis and delay the management. So this unusual nasal masses across the age group underscoring the need for vigilance in evaluation is the aim for this study. We included 4 patients aged between 14 and 68 years old with who came to the hospital with the complaint of nasal mass on diagnostic nasal endoscopy. We could see that at our tertiary care center. So first case, a 14-year-old male presented to the hospital with chief complaints of right-sided nasal obstruction, right nasal bleed, right cheek swelling since 6 months, and on diagnostic nasal endoscopy, the smooth pinkish mass was seen present in the right nasal cavity, extending till the vestibule, pushing the septum to the left, almost touching the left inferior turbinate, which was not sensitive to touch and not bleeding on touch, and probe could be passed all around. On CT scan, we could see the soft tissue lesion in the right nasal cavity, extending into eroding the medial wall of a right maxillary sinus and extending till the choana
with few calcification, pushing the medial and inferior wall of orbit upwards and laterally. And for this patient, endoscopic transnasal excision of tumor was done under general anesthesia. Entire mass was excised in bits and pieces and sent for histopathology, which was suggestive of olfactory neuroblastoma. Further, this patient was sent for post-operative radiotherapy. This olfactory neuroblastoma is a very rare, slow-developing but malignant tumor with high recurrence rate, accounting for only 2% of intranasal tumors. Second case of a 68-year-old lady came with a farmer by profession, presented to the hospital with the chief complaints of right-sided nasal obstruction, nasal discharge since 8 months, bilateral nasal bleed since 1 week. There was no history of hyponasal voice, snoring, mouth breathing was present, but history of dental pain was present, history of weight loss, loss of appetite, fatigue, and constipation was present. She was a known case of hypertension. On oral cavity examination, there was a soft ulcerative pinkish oral bulge was present over the hard palate, extending till the soft palate junction. On diagnostic nasal endoscopy, pinkish mass was present in the right nasal cavity, extending from anterior end of inferior turbinate till nasopharynx, which was sensitive to touch, bleeding on touch, pushing the septum to the left. CT scan showing the soft tissue lesion in the right nasal cavity, eroding the hard palate. Here we can see that. And soft tissue density was noted in the bilateral maxillary, right ethmoid, right frontal sinuses, eroding the medial wall of maxilla and deviated nasal septum to the left. Biopsy was taken from the mucosal bulge on the hard palate, and on histopathological examination, it came out to be as clear cell hydradenomas. So endoscopic transnasal excision of tumor was done, and inferior maxillectomy was done under general anesthesia, and obturator was placed to reconstruct the palatine defect. The clear cell hydradenomas of nose is an extremely rare benign sweat gland tumor, which appears as a solitary firm nodule on head and neck and extremities. But in the nasal cavity, it is a relatively rare condition. Third case, 14-year-old boy presented to the hospital with the chief complaints of right-sided nasal bleed since 12 months, swelling over the right side of a nose since 8 months, and bilateral nasal obstruction. There was a history of hyponasal voice, snoring, mouth breathing, cheek pain, and post-nasal discharge was present in this boy. And on diagnostic nasal endoscopy, smooth pinkish mass was present in the right nasal cavity, occupying completely, which was sensitive to touch, not bleeding on touch. Septum was pushed to the left, touching the inferior turbinate. I couldn't get the DNA photo. And on CT scan, we could see the soft tissue lesion in the right nasal cavity with a few calcification. There was a heterogeneity, which was extending till nasopharynx. And the mass was pushing the medial wall of maxilla laterally, and deviated nasal septum was found to be to the left. For this patient, management was done by lateral rhinotomy approach for excision of tumor under general anesthesia. Entire mass was excised and sent for histopathological examination, which was suggestive of extraskeletal Ewing sarcoma, which is a highly malignant, small, round cell tumor originated from the primary neuroectodermal cells. Ewing sarcoma is most common in children and young adults, but in long bones. But it is very rare in head and neck, and it is extremely rare in the nasal cavity and paranasal sinuses. Fourth case of 28-year-old male presented to the hospital with the chief complaints of recurrent episodes of bleeding from left nasal cavity since 7 months, and was associated with left-sided nasal obstruction and mucoid discharge. On diagnostic nasal endoscopy, smooth pinkish mass was present in the left nasal cavity till middle turbinate and filling the entire nasopharynx. CT scan was showing a well-defined soft tissue density mass noted in the left posterior nasal cavity extending into nasopharynx, laterally into left sphenopalatine foramen, suggestive of nasopharyngeal mass, likely nasopharyngeal angiofibroma. And endoscopic transnasal excision of tumor was done. This nasopharyngeal angiofibroma is more common in the young males, but this patient was an adult, which was uncommon, a typical presentation. The conclusion of my case series is the clinical presentation in most of the nasal masses will be often same. but high index of suspicion should be there for appropriate radiological investigations to assess the morphology, size, and extent of tumor for proper planning and management of a disease. Histopathological pattern of nasal cavity lesion vary from common benign lesions such as hyperplastic polyp to the malignant disease such as lymphoma and carcinoma. And time is very crucial and very critical to diagnosis. And these are some of my references. Thank you.
Sir, any questions from the judges, sir?
No, sir.
No, thank you.
Sir, sir.
Thank you, sir.
Next serial number 12, Dr. Rishabh. Are you there, Dr. Rishabh?
Yes, sir.
Dr. Rishabh?
Yes, sir. Can you hear me, sir?
Yeah. Kindly share your screen and present.
Yes. Yeah. Good afternoon, sirs and madams. Today I'm going to present a case series on tympanojugular paraganglioma. I named it as a noisy tumor because it generally presents with tinnitus and has a silent spread. It's a slow-growing tumor, and it also appears as a rising sun behind the tympanic membrane. So coming to the introduction, tympanojugular paragangliomas are the most common benign tumors of the middle ear, as we know, and the second most common tumors of the temporal bone. So they have varying clinical presentations. They may involve just the middle ear, or they may extend into the mastoid cavity, or they may involve the infratemporal fossa as well. So my topic mainly rotates on that. Coming to the statistics, the male to female ratio is generally 5:1. Tympanojugular paragangliomas are more common in females as compared to males. They generally present in the age group of 30 to 60 years, averaging about at 40 years of age. Now coming to my aim and my objectives, where I have presented, I have prepared a comprehensive case series of 3 cases, each involving a different anatomical presentation of tympanojugular paraganglioma. One involving just the middle ear, one involving the extension to mastoid cavity, and one involving extension to the jugular bulb, and the different surgical approaches we have done and the different methods we have used. Coming to case 1, it's the case of a 42-year-old female patient with history of pulsatile tinnitus, and she was admitted to the hospital with main complaints of pulsatile tinnitus only, although she had a presentation of hearing loss, which was of 4 months duration. Coming to the examination, all the throat and oral cavity examination was normal. The nose examination was completely normal. Then on endoscopy, there was a reddish mass observed in the anterior quadrant of the tympanic membrane of the patient. Then Puton audiometry revealed a conductive type of hearing loss. Coming to HRCT, it revealed a soft tissue density in the left temporal bone scan, which was occupying only the left middle ear cavity, as you can see here. This is the endoscopy finding. As you can see, there's a mass occupying the anterior quadrant of the tympanic membrane. Now, based on the above clinical findings, patient was clinically diagnosed as a case of tympanomastoid paraganglioma, FISH A. Coming to FISH classification, FISH A involves only the middle ear cavity. When there is extension into the mastoid, it becomes FISH B. FISH C is extension into the apical regions and the infratemporal regions. FISH D is where there is intracranial extension. Now, as this tumor has only involvement in the middle ear cavity, so I named it as FISH A. And the approach for this tumor was via transcanal approach. This is a brief surgery of the patient, where the patient was operated transcanally by a transcanal approach using microscope. As you can see, the tumor is being visualized completely here. It's being separated from the handle of malleus. There is cauterization of the tumor. As we know, glomus tumor is extensively vascular, and the blood supply has to be taken care of, like prevent blood loss. The tumor is being completely excised and removed from the middle. Yeah, coming to the second case. This is a case of a 48-year-old female patient with history of pulsatile tinnitus, coming to the hospital with main complaints of hard of hearing in her right ear for a duration of 1 year. Although she had complaints of tinnitus and dizziness as well, her main complaints were hard of hearing and dizziness. Again, coming to the other examination, the throat and the nose examinations were completely normal. Patient had no history of any trauma, also no history of any acoustic hearing loss. Now, upon examination, the endoscopy, it revealed a red mass which was observed in the left ear, occupying the lower part of the tympanic membrane, which was pulsatile and became more prominent with valsalva maneuver. Q10 audiometry revealed a mixed type of hearing loss pattern in the right ear. Coming to the HRCT, we can see that the tumor is involving a part of the middle ear as well as the part of the mastoid cavity, as you can see here. This is the mastoid involvement we can see in the lower scans, and there is middle ear involvement as well in the further. So the extension was mainly into the middle ear cavity and the attic and otitis. Now, patient was clinically diagnosed as a case of tympanomastoid paraganglioma type fish B and operated via transmastoid approach, as there was involvement of the attic, otitis, and mastoid cavity as well. This is a brief surgery of the tumor excision. There were the canal wall down mastectomy was done, as the tumor was extending through the otitis into the mastoid, and it was difficult to approach for the tumor. We can see that the tumor is being cauterized and removed in pieces. There was an extreme vascularity of the tumor, so we had to use a bipolar cautery for the complete excision of the tumor, along with the debrider. As you can see, the blood loss. Tumor was mainly involving the attic epitympanum. It was also involving the epitympanum and around the eustachian tube, as well as the hypotympanum as well. Yeah. Now, the histopathology report confirmed the diagnosis suggestive of paraganglioma. Now, coming to the third case, this was a relatively difficult case. There was a 41-year-old female presenting with complaint of low frequency pulsatile tinnitus. So she also had a complaint of hearing loss, but which was not very significant for her. She had a complaint of pulsatile tinnitus, which was not alleviated with any noise, and was there since a duration of 1 year. So again, coming to the throat and nose examination, there were no any abnormalities found, and there was no any history of acoustic trauma, mechanical trauma to the ear. So upon examination, endoscopy revealed a reddish mass observed in the left ear, causing a bulge in the lower part of the tympanic membrane, but which was very clearly pulsatile. But coming to the valsalva maneuver, the tumor was not very prominent, and coming to pure tone audiometry, it revealed a conductive pattern of hearing loss. So on examination, we can see the CT scans. It shows a tumor involving the middle ear cavity with extension into the jugular bulb as well. Here we can see the erosion of the jugular spine as well, with the extension of the tumor into the infratemporal region. So the tumor was identified as clinically identified as tympanomastoid paraganglioma with extension into the jugular bulb. So tympanojugular paraganglioma type fish 3, and operated by an infratemporal fossa approach. Let me give you a brief description of what exactly was done here. This is the external auditory canal. This is the mastoid cavity, and the styloid process was completely removed, exposing the complete facial extratemporal facial tract, and the lower cranial mass was separated and salvaged. So here we can see the jugular bulb is ligated here, and the tumor extension can be seen extending from the near the jugular bulb, extending all the way to mastoid cavity and involving the middle ear as well. So the tumor was completely excised. It was a very extensive tumor. As you can see, the tumor was highly vascular and bleeding. The biopsy confirmed the diagnosis of paraganglioma. This was the size of the tumor, although a part of the tumor was completely cauterized and removed. And as you can see, this was a post-surgery scar. It healed after 1 month of surgery. This was taken after 1 month of surgery. This tumor was very extensive and required blind sac closure of the ESC as well, as you can see here. Now, coming to the statistical comparison of different approaches, as you can see, the transmastoid approach is used for those fish B classification tumors, and you can see the complications are relatively higher as compared to the transcanal approach. But when compared to the infratemporal approach, the complications of the surgery, that's the facial nerve palsy, which happened in our patient post-op. She had grade 2 facial nerve palsy, and there's a high risk of hearing loss as well as CSF leak. Now, since the patient had a blind sac closure of the ESC, there was loss.
Dr. Rishabh, your time is over. Moving to the next presenter, serial number 13, Dr. Mudit. Are you there?
Sir, I'm
Dr.
here.
Mudit? Yeah.
Am I
Present
audible?
your screen. Yes. Present your screen. Start your presentation.
Good afternoon, sir.
I'm going to present my paper on extended high frequency audiometry in type 2 diabetes, a cross-sectional study. So as we know that the India is a diabetic capital of the world, and the type 2 diabetes lead to the chronic disorders targeting microvasculature and the neural complications. So basal turn of cochlea is actually more vulnerable because of rich blood supply, and it causes high frequency hearing loss. So the conventional PTA, which is from 25 hertz to 8 kilohertz, may miss the chance to diagnose it. So my study is based on high frequency hearing, testing 9 kilohertz to 18 kilohertz, detect the early dysfunction. So objective is to evaluate the extended high frequency in type 2 diabetes, compare the diabetes with the controls, and correlate the HbA1c and the duration of diabetes with the hearing loss. So this was a cross-sectional study for 8 months. There were 150 participants, which were divided into 2 groups, 75 type 2 diabetic patients and 75 for controls, matched, sex matched. The audiometer used was DSI Palo, which test from 125 hertz to 20 kilohertz. This was the extended high frequency. I also tested HbA1c, fasting blood sugars, postprandial blood sugars. So the key results were that the PTA among 2 groups were nearly normal, but extended high frequency threshold were increased in type 2 diabetes patients with p-value less than 0.01. The duration of diabetes was the strongest predictor, and HbA1c has a borderline effect. So these are some graphs which is showing the mean extended high frequency threshold is raised in type 2 diabetes mellitus. So this is the scatter plot, which is also correlating with my finding that as the HbA1c level raises, extended high frequency threshold also raises. This is the averages of the between the 2 groups, controls and type 2 diabetic mellitus, and we see the difference between these 2 lines. So the conclusion was that extended high frequency audiometry is a sensitive for early cochlear damage. It can help us in prediction of early hearing loss. It detects changes before PTA, conventional. It should be integrated into diabetic care. Future direction that some more longitudinal studies are being required. Multi-center validation is to be required, and it also can be combined with the objective test, which are OAE and ABR. These are my references.
Are there any questions?
Any limitations of your study?
So the one limitation is there that this device of extended high frequency audiometry is expensive. That's why it is not used more commonly.
Because this is subjective. Okay, thank you.
Next presenter, serial number 14, Dr. Bhavana. Dr. Bhavana, are you there?
Yes, sir.
Yeah, kindly share your screen and present.
Can I start, sir?
Yes, start.
Good afternoon, everyone. My case series topic is Beyond the Clinical Eye, Histopathology Rewrites Spy Diagnosis. Introduction. This case series presents 5 diverse EI cases where the preoperative diagnosis significantly differed from the final postoperative histopathological diagnosis. These cases underscore the limitations of preoperative assessment tools and highlight the role of histopathology in establishing a definitive diagnosis. Through these examples, we aim to shed light on the importance of maintaining a broad differential diagnosis and the need for cautious interpretation of preoperative findings in ENT practice. My first case, a 32-year-old male presented to ENT outpatient department with a complaint of growth over hard palate. There is no history of pain and trauma. On examination, there is an exophytic lesion on center of hard palate, approximately of size 1 into 1 centimeter. There is blackish discoloration. On palpation, non-tender, hard in consistency, pedunculated, non-fluctuant, and did not blanch on pressure. Differential diagnosis included torus palatini, melanoma, minor salivary gland tumors, and hemangioma. After infiltration is given, the pedicle is cut and the specimen is removed. Surgical excision was performed and specimen was sent for histopathological examination, which suggested features of fibroma hard palate. Histopathology, unencapsulated mass of dense fibrous connective tissue, often with varying degrees of collagen, and a surface covered by hyperplastic or hyperkeratotic squamous epithelium. Lymphocytes are present, no cellular atypia or mitotic activity. My second case, 10-year-old female presented to ENT outpatient department with a complaint of growth in the right nostril, which bleeds on probing. On examination, a round pinkish vascular mass is seen attached to anterior nasal septum, non-tender and bleeds on touch. Differential diagnosis included bleeding polypus, inflammatory fibrous polyp, androconal polyp, and pyogenic granuloma. Surgical excision was performed and a specimen was sent for histopathological examination, which suggested features of angiofibroma. These are the pictures of preoperative and postoperative pictures. Histopathology, there is stromal proliferation of fibroblast with mild pleomorphism and spindle to plum shaped and few stellate cells noted. Features suggestive of angiofibroma. My third case, a 12-year-old female presented to ENT outpatient department with a complaint of swelling over left upper gingivobuccal sulcus, which is insidious in onset and progressive in nature, associated with pain. History of trauma to face present. No history of any comorbidities or previous surgeries. On examination, single smooth swelling present over over left upper gingiva, approximately of size 2 into 2 centimeters, non-tender, firm in consistency. CT head and neck was done and features suggested of expansile osteolytic lesion involving maxilla. The differential diagnosis included dentigerous cyst, adenomatoid odontogenic tumor, and calcifying odontogenic cyst. In this case, after proper blood investigations are done, this case is administered under general anesthesia and the incision was given and the dissection was continued. This is the picture after the specimen was removed, the picture of empty fossa, and the closure is done with simple sutures. And this is the picture of excision biopsy specimen. Surgical excision was performed and specimen was sent for histopathological examination, which suggested features of benign adenomatoid odontogenic tumor. Histopathology. Sections show encapsulated lesion composed of cuboidal, spindle, and columnar epithelium cells arranged in nodules, rosette pattern, and duct-like structures. There is pinkish deposition of eosinophilic matrix and shows areas of hyalinization. My fourth case, a 21-year-old female presented to ENT outpatient department with a complaint of swelling behind right ear, which is insidious in onset and gradually progressive, not associated with pain. No history of any trauma. On examination, single round swelling present in the right post-auricular area, approximately of size 3 into 3 centimeters, cystic in consistency, no local rise of temperature or tenderness noted. Ultrasonography was done and suggested evidence of 4.7 into 2.6 centimeters sized, well-defined heterogeneously hypoechoic lesion with surrounding anechoic area having internal echoes showing posterior acoustic enhancement and no internal vascularity. Differential diagnosis included sebaceous cyst and lipoma. After surgical excision was performed and specimen was sent for histopathological examination, which suggested features of keratinous cyst with secondary inflammation. These are the pictures of excision biopsy specimen and the closure. My fifth case is a 58-year-old female presented to ENT outpatient department with a complaint of swelling over right upper lip mucosa, which is insidious in onset and gradually progressive, not associated with pain. On examination, an ovoid swelling is present over right upper lip mucosal surface, approximately of size 2 into 2 centimeters, non-tender, firm in consistency. Ultrasonography was done, which suggested evidence of 2.7 into 1.3 centimeter sized, well-defined, heterogeneously hypoechoic lesion with no significant vascularity and few cystic areas noted in subcutaneous planes of right upper lip. Likely epidermoid cyst. After surgical excision was performed and specimen was sent for histopathological examination, which suggested features of pleomorphic adenoma. These are the pictures of preoperative and postoperative period. Histopathology, a mixed tumor containing both epithelial cells and mesenchymal components within varied stroma and its characteristic pleomorphic appearance. Conclusion. This case series highlights the diagnostic variability that can occur between preoperative assessments and final postoperative histopathological findings in ENT practice. Despite advancements in imaging and cytological techniques, certain lesions continue to pose diagnostic dilemmas due to overlapping clinical and radiological features. These cases underscore the critical importance of histopathological examination as the definitive tool for accurate diagnosis. My take-home message is awareness of such potential cases is essential for ENT surgeons to approach each case with diagnostic caution, maintain a broad differential, and provide appropriate surgical planning and counseling. Ultimately, integrating clinical suspicion with histopathological confirmation ensures the highest standard of care and optimal patient outcomes. These are my references. Thank you, sir.
When do you want immunohistochemistry, or could I put it like, what are the indications for immunohistochemistry?
Sir, when we have a doubt in confirming, we go for immunohistochemistry help to confirm the diagnosis or origin of metastasis.
And
for any treatment responses.
Okay, thank you.
Thank you, sir.
Next presenter, serial number 15, Dr. Ratna. Are you there?
Yes, sir.
Kindly share your screen and present.
Yes, sir. 1 minute, sir. Sir. Sir, can I?
Your screen is not visible, Amma.
Sir, can I start, sir?
Start. But your screen is not visible.
Sir, can I start, sir?
Start, Amma, start.
Sir.
I think you have to share your screen.
Yes, sir. Sir, can I start now, sir?
Start, Amma.
Yes, sir. Good afternoon, everyone. I'm here to present a case series of oral cavity hemangiomas. Introduction. Hemangiomas are benign vascular lesions which arise due to the which arise due to an abnormal proliferation of endothelial cells and are often classified as vascular tumors. In the oral cavity, hemangiomas can occur on the lips, tongue, buccal mucosa, gingiva, palate, etc. Clinically, they present as soft, compressible, red to bluish lesions that may blanch on pressure. Histologically, oral hemangiomas are broadly divided into capillary, cavernous, mixed types, while many hemangiomas undergo spontaneous regression, some persist and require intervention.
Doctor, I think you have to share your presentation.
Sir, 1 minute. Sir, am I visible now, sir?
Continue, Amma. Continue. Timer is running. Kindly continue.
Yes, sir. Sir.
Continue. It is visible, Amma. Continue.
Sir, I was not able to
Okay.
continue
Okay.
the presentation, sir.
Fine. Fine. Fine.
So can you please stop the timer, sir? Sorry for this inconvenience, sir.
Timer is stopped. Don't worry. You continue.
Thank you, sir.
Start, Amma. Start.
Sorry for the inconvenience, sir.
Start.
Introduction. Hemangiomas are benign vascular lesions which arise due to an abnormal proliferation of endothelial cells and are often classified as vascular tumors. In the oral cavity, hemangiomas can occur on lips, tongue, buccal mucosa, gingiva, palate, and etc. Clinically, they present as soft, compressible red to bluish lesions that may blanch on pressure. Histologically, oral hemangiomas are broadly divided into capillary, cavernous, mixed types. While many hemangiomas undergo spontaneous regression, some persist and require intervention. Sir, are you able to see my screen, sir?
Yeah, you can continue.
Slide share పెట్టకు.
ఇది గ్రీన్ లో ఉంది అందుకే
Congenital hemangiomas are visible at birth, whereas infantile hemangiomas may appear later. Theories of formation of hemangiomas. The most likely hypothesis suggests that hypoxic stress upregulates expression of glucose-1 transporter and vascular endothelial growth factor, leading to the mobilization of endothelial progenitor cells. Second theory, placental trophoblasts serve as the origin of stem cells for hemangiomas. Third theory, infantile hemangiomas development involves vasculogenesis from progenitor cells as well as the formation of new vessels from the existing ones. Aim. To study the clinical presentation, distribution, and demographic profile of hemangiomas in the oral cavity, to evaluate the diagnostic modalities and management approaches for the oral hemangiomas, to analyze the complications, recurrence rates, and long-term prognosis of the oral cavity hemangiomas. Materials and methods, sample size 5, inclusion criteria, both sexes, lesion in the oral cavity, cases for which intraoral UAG suggested as hemangiomas were included in the study. Exclusion criteria, immunocompromised patients, bleeding disorders, and patients with a history of previous malignancies were excluded from the study. Case 1, a 13-year-old female came to our outpatient department with complaints of swelling over left side of tongue since 2 years, which was insidious in onset and gradually progressive and not associated with any pain. Intraoral USD suggested as well-defined lobulated anechoic septated lesion noted in the anterior two-third of the left side of the tongue, measuring about 10 into 9.8 mm with minimal internal vascularity on Doppler, feature suggesting as vascular malformation. On examination, a ovoid swelling present over anterior two-third of the left side of the tongue measuring about 1 into 1 centimeter, and there was bluish discoloration over swelling, no discharge, and sinuses over swelling were present. Swelling was non-tender and firm in consistency. Treatment. After proper investigations, excision was planned for this case. Initially, after administering the general anesthesia, the tongue was secured with the help of chain retractors and with the help of vitral suture material. And then infiltration was given all around the lesion and on the lesion. Now, for minimalizing the bleeding, coagulation was done around the lesion using the monopolar cautery. Around the lesion, circumferential incision was given using the monopolar cautery, and then dissection was carried out using the monopolar cautery and also the bipolar cautery. Now, for closure, simple continuous sutures were used. The specimen is sent for histopathological examination, and this is a picture showing on the day of postoperative day 9. Histopathology, fragment of tissue lined by stratified squamous epithelium with focal plexiform papillomatosis, stroma showing numerous proliferating capillaries and extensive areas of hemorrhages. Features are suggestive of capillary hemangioma. Case 2. A 49-year-old female came to our outpatient department with the complaints of swelling of right buccal mucosa since 1 year, which was insidious in onset and gradually progressive and not associated with any pain. Intraoral USG suggested well-defined heterogeneous hypoechoic lesion noted in the right buccal mucosa with increased vascularity on Doppler measuring about 15 into 13 mm, suggestive of vascular malformation query hemangioma. On examination, a bluish mass present over right buccal mucosa of size 1 into 1 centimeter, extending from the level of right lower second premolar to first molar. No discharge and sinuses were seen over the swelling. Swelling was non-tender and cystic to firm in consistency. Size of the swelling increasing on giving pressure externally. Treatment. After proper investigations, excision was done, and initially after administering the general anesthesia, dissection was done using the cautery, and then for the closure, local buccal rotational flap was used as a graft, and then for the closure, simple sutures were done in W pattern, and the specimen was sent for histopathological examination. Histopathology, fragments of tissue focally lined by stratified squamous epithelium with numerous dilated vascular spaces with intraluminal red blood cells admixed with the normal salivary glands, along with the areas of hemorrhages. Features are suggested as cavernous hemangioma. Case 3. This is a case of 10-year-old male presented with the complaint of growth over hard palate, for which intraoral USG suggested as hemangioma. Excision was done and sent for histopathology, which confirmed the features of hemangioma. Case 4. Patient 12-year-old female came with complaints of growth over right side of the tongue, for which excision was performed and sent for histopathology, which confirmed the features of hemangioma. Case 5. 1-year-old female baby came with the complaints of growth over lower lip. And then after intraoral USG, hemangioma was which suggested as hemangioma, and excision was performed and sent for histopathological examination, and which suggested the features of hemangioma. Discussion. For all the cases, intraoral USG was performed preoperatively and surgery was performed after routine blood investigations. We made sure that lesion was excised without leaving any remnant to avoid recurrence. Preoperative and postoperative diagnosis for all the cases are same and confirmed with the histopathological findings. All cases were followed up for 12 weeks postoperatively. Healing was good and no recurrence was seen. Patient consent was taken for all these cases. Conclusion. Oral cavity hemangiomas, though benign, pose significant risks due to their vascular nature and location. The major concerns include bleeding, ulceration, functional impairment, cosmetic deformity, and recurrence. Early recognition and timely intervention are key to prevent complications. Recurrence is low in well-circumscribed lesions that are completely excised. Surgical excision is effective in well-localized lesions, while diffuse lesions may require multimodal therapy like adjuvant sclerotherapy and embolization. Take-home message. Surgical excision not only ensures complete removal but also provides histopathological confirmation. These are my references. Thank you, everyone.
Sir, 15 presenters are over. I think Sushmita has joined. Can I ask her to present?
Yes, Sagar.
Dr. Sushmita? Dr. Sushmita, are you there?
Sir, can I stop sharing my screen, sir?
Yeah, stop, Mama, stop. Dr. Sushmita, are you there? Dr. Ashia? Dr. Aparna. Dr. Sushmita, Dr. Asya, Dr. Aparna.
Sagar, tell the serial number also.
Serial number 1, Dr. Sushmita, are you there? Serial number 3, Dr. Asya Khatun, are you there? And serial number 9, Dr. Aparna, are you there? I think they are not there, sir. So can we end the session or shall we wait for some time?
Give 5 minutes, sir.
Yes, sir. Yes, sir. Yes, sir.
After 5 minutes, we'll close the session.
Yes, sir. Yes, sir.
And to set up judges.
Yes, sir. Yes, sir.
Revati, you call them once.
We already called, sir. Sushmita is telling that she is not able to connect. Asya is not responding. Aparna will call, sir. Revati will call, sir.
Yeah. Just give the
They're
5
not
minutes.
answering the call, sir.
Okay, so only Sushmita is responding, sir. Other two are not answering, so we'll mark them as absent.
That use another friend's laptop or internet.
Yes, sir. Only I'm asking. Okay, fine.
Request respected judges, please bear for 5 minutes.
Okay.
Thank you, sir. Sir, otherwise we will call the number 16th candidate and finish this session, sir.
Yeah, okay, sir.
Yeah.
Presenter number 16.
Candidate and finish this session.
Yes, sir. Presenter number, serial number 16, T. Venkateshwarlu, are you there?
Yes.
Yes, sir.
Kindly share your screen and present. Yes, start.
Yes, sir. Thank you, sir. Role of platelet-rich plasma in enhancing graft uptake in tympanoplasty.
Sorry, sir. For the inconvenience. Sorry for the inconvenience.
Sorry for the inconvenience, sir.
Yeah,
Can I
continue.
start, sir?
Continue.
Sir, introduction. The tympanic membrane separates the delicate structures of middle and inner ear from the external environment. Tympanic membrane perforation is a permanent abnormality of the pars tensa, pars flaccida, most likely a result of earlier acute otitis media, negative middle ear pressure, otitis media with effusion or trauma. Tympanoplasty is the repair of eardrum and restore ear function, often improving both quality of life and ear health. Tympanic membrane perforation can be successfully repaired as with graft materials. Commonly used grafts includes autologous temporal fascia, perichondrium, cartilage, and adipose tissue. Some grafts show undesirable pathologic changes such as proliferation of fibrous tissue and thickening of graft, resorption, and excessive thinning. Therefore, there is a still need to search for methods to enhance tympanic membrane healing after tympanoplasty to increase success rate. Platelet-rich plasma represent an emerging biotechnology current tissue engineering and cellular therapy. Objectives: surgical closure of tympanic membrane perforation still remains the choice of management. The aim of my study is to study the effect of application of platelet-rich plasma in the closure of tympanic membrane central perforation of size less than 7 millimeters. Materials and methods: study design and setting, prospective case control study, study period 6 months, August 2024 to February 2025, sample size is 20 numbers. Source of data: all the patients with the tympanic membrane perforation less than 7 millimeters who attend the ENT department from August 2024 to February 2025 and who compile with inclusion and exclusion criteria. Inclusion criteria includes central perforation of tympanic membrane, perforation of size less than 7 millimeter, dry ear for more than 6 months, functional eustachian tube, airborne gap in pure tone audiometry less than 41 decibels, good cochlear reserve. Coming to exclusion criteria: attic and marginal perforations of tympanic membrane, perforation of size more than 7 mm, dry ear less than 6 months, dysfunctional eustachian tube, airborne gap in pure tone audiometry more than 42 decibels, poor cochlear reserve, bleeding and clotting disorders. Methods of collection of data: patients who satisfied the mentioned criteria for selection taken as subjects for the study. After taking an informed and written consent, the selected patients were subject to clinical, audiological, and laboratory investigations, detailed history of the patient, general and systemic examination of the patient, examination of tympanic membrane under microscope was done, and hearing evaluation using tuning fork test. Pure tone audiometry, CT temporal bone, and relevant laboratory investigations including hemoglobin, RBS, serum creatinine, and serum urea was done. 10 patients underwent tympanoplasty under anesthesia, post-auricular or end oral incision made. Elevation of tympanomeatal flap was done, followed by freshening of perforation of margins done to stimulate healing. Vascular chain and middle ear status are checked. Tympanomeatal flap reposes in external auditory canal is packed with antibiotic soaked gel foam. Skin incision is closed. 10 patients underwent tympanoplasty under anesthesia, post-auricular or end oral incision made. Graft is harvested and soaked in platelet-rich plasma for a few minutes to enrich it with growth factors. A few drops of platelet-rich plasma applied directly over the perforation edges and middle ear mucosa. The platelet-rich plasma is soaked graft placed over the perforation. Gel foam pieces soaked in platelet-rich plasma placed to support the graft. Tympanomeatal flap reposition. External auditory canal packed with antibiotic soaked gel foam. Skin incision is closed. Preparation of platelet-rich plasma. Around 5 to 10 ml of patient's peripheral blood is withdrawn under aseptic conditions. Centrifugation done. First spin separates the plasma and buffy coat from the blood cells. Second spin concentrates platelets in the lower part of the plasma. The platelet-rich layer is collected. Patient demographics. Total patients 20. Age 15 to 50 years. Male to female ratio 12 is 8. Right to left ear 11:9 ratio taken. Affected ear. Type of tympanic membrane perforation. Small less than 5 mm is 5 numbers. Medium size 5 to 6 millimeters is 12 patients. Large 6 to 7 mm 3 patients are taken. Graft uptake with platelet-rich plasma. Success rate is 90% observed. Failure rate is 10% observed. Graft uptake without PRP. Success rate is 75 observed. Failure rate is 25 is observed. Hearing improvement with platelet-rich plasma. Improved 85%. Not improved 15%. Hearing improved without platelet-rich plasma. Improved 65%. Not improved 35%. Complications with platelet-rich plasma. No complications 95%. 5% complications with PRP. Complications without platelet-rich plasma 85%. 15% with complications are observed. Discussion. Platelet-rich plasma is autologous concentrate of platelets containing growth factors such as platelet-derived growth factor, vascular endothelial growth factor, epidermal growth factor, and transforming growth factor beta. These molecules play a vital role in tissue regeneration by promoting angiogenesis, collagen synthesis, fibroblast proliferation, and epithelial migration. Platelet-rich plasma improves graft uptake graft uptake rates, accelerate epithelialization of tympanic membrane, and enhances hearing outcomes. The growth factors of platelet-rich plasma provide microenvironment for healing, reduce the risk of graft rejection. Platelet-rich plasma is safe, cost-effective, and easy to prepare intraoperatively, and it minimizes the risk of immune reactions or disease transmission. Limitations of platelet-rich plasma must consider includes the concentration of platelet-rich plasma not standardized. Long-term results are still under evaluation. Large randomized control trials are need to validate its efficacy. Current evidence supports platelet-rich plasma as a valuable adjuvant, combines surgical repair with biological regeneration. Conclusion: platelet-rich plasma in tympanoplasty is safe, simple, and cost-effective adjuvant that enhances graft uptake, accelerates healing, improves hearing outcomes by utilizing patients' own growth factors. It is
Doctor, your
useful
face
in-
is not visible. Okay, continue.
It is useful in large preparations, revision cases, and patients with poor healing potential. Long-term studies are required. Current evidence strongly supports platelet-rich plasma as promising tool to improve overall success of tympanoplasty. These are my references. Thank you, sir.
Yours is a comparative study?
Yes, sir.
But why you put that word hearing not improved? Hey, are you right in putting that word? You mean to say hearing is not at all improved or what?
More improved, sir.
Huh?
With PRP, improvement is more, sir.
No,
Actually,
have you compared with your other studies? In other cases,
sir.
what you have done? You have done meringoplasty?
Tympanoplasty we are done, sir.
Yeah. But why you have put that word hearing not improved?
Comparatively, sir, hearing is improved with
No,
PRP,
you
sir.
should use the right word. What is GFC? You heard about growth factor concentrate?
Yes, sir.
What is that? How does PRP prevent infection?
Sir, vascular endothelial factor growth factors are there, sir. These will release oxygen and some nutrients.
What is there in the PRP that prevents infection? Okay, thank
They
you.
promote tissue regeneration particularly.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, judges, for supporting our
Thank you,
conference.
sir. Thank you for
Dr.
giving this
Anil Kumar,
opportunity.
Yes, sir. Shravana Selvan,
Thank
sir.
you.
Yeah,
Thank
we
you,
will
sir.
finishing this session, sir. I will be in touch with you in the
Okay.
WhatsApp, sir. Thank you so much.
Okay.
On behalf of
Thank
our
you, sir. Thank you.
yes, sir. Yes, sir. Yeah, sir. We are moving into the next session. Before moving to the next session, I request Dr. Deepthi and Dr. Maunika from Gandhi Medical College moderate this session and keep the CVs of next judges. Dr. Sriharsha, are you there? Sriharsha.
Hello.
Yeah. Deepthi, madam.
Hello.
Hello. Madam, cheppandi.
Hello. Good afternoon.
Yeah, good afternoon, ma'am.
Good afternoon. I'm going to introduce now judges from now for the second session. First judge is Dr. Ravi D. He is Professor and HOD, Department of ENT, Mandya Institute of Medical Sciences, Mandya, Karnataka. Then he has completed his MBBS from Bangalore Medical College, Bangalore University, MSc ENT from Jipmer, Pondicherry, DNB ENT from NBA, New Delhi. His designation right now is Professor and HOD in MIMS, Mandya, till date.
He has many achievements, academic achievements, and membership of professional bodies. He is a member of US RGUHS Bangalore. He is a member board of studies PG Adichu Chanagiri University. Member National Board of Medical Sciences, Member AOI National Branch, Secretary AOI Karnataka State Branch, Treasurer of Institutional Scientific Committee MEMS Mandya. And academic achievements, first rank in MSc ENT Pondicherry University, 35 publications in both national and international journals, internal and external examiner for both undergraduates and postgraduates, postgraduate guide from 2015, MCI and NMC assessor for both UG and PG courses, administrative experience, academic registrar of MIMS Mandya from 2011 till date, Deputy Chief Superintendent of MIMS Mandya from 2010 till date, Coordinator Digital Valuation RGUHS, active member of Curriculum Committee Mandya. We welcome Dr. Ravi sir. Hello. 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 Sriharsha, are you there? Sriharsha? Hello. Hello. Welcome, Dr. Ravi sir. Hello. Sir, am I
Welcome,
audible?
sir. Yes, madam.
Welcome,
You can
sir.
continue. Yeah.
Our next judge is
Dr.
Dr.
M.B.
Bharati.
Bharati.
Dr. M.B. Bharati madam, immediate past president of Association of Otolaryngology of India, vice president of SARC ENT Association, senior professor and HOD, head of the department of JSS Medical College, attached to JSS Academy of Higher Education and Research, Mysuru. Also heads the head and neck services and cochlear implant program of JSS Hospitals. Is a BC Roy awardee and has received the Best Teacher Award. Has been honored with Lifetime Achievement Award. Has numerous publications in national and international journals. Invited faculty, operating faculty, as well as speaker in various national, regional, and international conferences. Main area of interest are head and neck tumors, cochlear implant, skull base and OSA, and airway surgeries. He is an undergraduate and postgraduate teacher and has involved in various research activities, instrumental in developing mobile app for testing hearing disability, JSS Shravana app, has organized national and South Zone conferences and workshops, conducts regularly cadaveric temporal bone and head and neck dissection courses. We are honored to be here. We are honored Dr. Bharati MB madam is here with us. Thank you. We welcome madam.
Deepthi madam, just a minute, madam is joining. Hello, sir. Hello, sir.
Hello.
Sriharsha.
Sir,
Sriharsha ma'am join అవుతున్నారు 1 minute.
Okay.
As soon as madam joins, we'll start.
Okay.
Keep the ready. Next candidate ready, ma'am.
Okay. We have just
number 16th candidate over, madam. Before 3 are pending. I think 2 might be absent. One has a technical issue. Ravi sir, we are starting from the serial number 17, sir. 16th candidate already over, sir, just now. Deepthi madam, please take care of the
serial number 17.
Keep the candidate ready. Ask
yes,
them to share the screen and keep the ready.
Our next candidate is Dr. Gunukula Sriram Reddy. Are you ready now?
Good evening, ma'am. I'm ready, ma'am.
We'll start once the madam logs in.
Okay, ma'am.
Be ready with your screen.
Yes, ma'am. Yes, ma'am. I'm ready.
Your serial number?
17, sir.
17th. Okay.
Sir.
Right. Sriharsha?
Sir.
Any issue with the joining? Can you
No,
check?
no, no. Madam has joined, sir.
Joined, huh? Yeah, good afternoon, madam. Welcome, Bharti ma'am.
Good afternoon, madam. Good afternoon, Bharati madam. Welcome to the second session. With your permission and Dr. Ravi sir, can we start the second session? Madam? With your permission, madam, can we start the second session? Bharti madam, you are not audible. Kindly unmute, madam. Sriharsha,
Madam,
are you there?
I'm there, ma'am. Ma'am,
He is speaking. I think there is some issue with madam.
I think madam
Madam
is
is
not here at the system. We have to wait for her.
Madam is speaking
Connection
actually.
is it? But
I
madam, you
can
have to
see.
unmute. Ma'am, I've sent you unmute request. Kindly accept it. I've requested unmute.
Harsha, I think you have to call her.
I will do that.
Now?
Yeah, we are audible, ma'am.
Yes, ma'am. You are
Hello?
audible now. Welcome, madam.
Yeah,
Welcome.
now it's showing green. I think I'm muted now. Just check.
You are unmuted, madam. We can hear you.
No? Hello?
Yes, madam. Yes,
Deepti?
madam. You are unmuted. Yes, I'm Deepti. I'm coordinating this session, madam. Welcome. Welcome to the session. With your permission, madam, can we start the session?
Now you can hear?
Yes, madam. I
Yes,
can.
ma'am.
Can you hear?
Yes, ma'am.
Okay,
Yes.
yeah.
Can we start, madam?
Yeah.
Can we start the session?
Yes.
Yes.
Yeah,
Dr.
this is a
Ma'am?
case series, madam. There is a time limit is 8 minutes only. If the candidate finishes within 8 minutes only, you can take the questions. But otherwise, no questions allowed after 8 minutes. Okay.
Yeah.
Thank you. Yeah, we'll start.
Okay.
Dr. Deepti, ma'am, you can go ahead.
Yeah.
Yes. Yes, yes. Dr. Sriram, start your presentation.
Ma'am, yes. Good afternoon, ma'ams and sirs. My presentation topic for today is nasal splints in septoplasty. Introduction. Septoplasty is one of the most common surgery in otorhinolaryngology. Nasal packing is used primarily to control bleeding in all endonasal surgeries. Packing also facilitates internal stabilization following surgery on the cartilaginous and bony skeleton of the nose. Packing helps in preventing complications of septal surgeries like hematoma, infections, and abscess formations, but some complications like mucosal injuries, sleep disturbances, aspiration of various packing materials, eustachian tube dysfunction occur with packing group, which questions the wisdom of using this type of packing method. Aim of the study. Aim of the study to evaluate patient comfort, pain levels, and tolerance with nasal packing versus nasal splints to assess complications such as bleeding, septal hematoma, synechia formation, and infection in cases managed with nasal packing compared to those with nasal splints. To determine the relative efficacy of nasal packing and nasal splints in providing septal stabilization and maintaining surgical correction. To analyze the overall effect of nasal packing versus nasal splints on quality of life and recovery in early postoperative period. Materials and methods. Study design. A comparative study in which 80 patients were studied during the period of 12 months. Inclusion criteria. All patients with deviated nasal septum between 18 to 60 years of age. 18 to 60 years age group. Exclusion criteria. Patient with history of previous septal or turbinate surgery. Patient using hemodiluting agents, patient with history of nasal polyps or drug abuse, patients with bleeding diathesis and other medical disorders are excluded from the study. These are the pictures showing silicone nasal splints, splint selection and trimming while application, and this is the suturing picture showing suturing. We sutured using 8-shaped transseptal sutures. This is a video showing post-operative splint removal. We removed the splint after 8 days post-operatively, and which showed less crusting and less bleeding. Methodology. Patients were divided into two groups, Group A and Group B. In Group A with intranasal splints, silicone septal splints were placed fixed by 8-shaped transseptal sutures with 306 suture material, which were removed after 1 week postoperatively. In Group B, without intranasal splints, regular nasal packing was done, which was removed after 48 hours postoperatively. Both the groups were followed up regularly at 1 week, 3rd week, and 2 months postoperatively. This is the graph showing patient count by age. Group with intranasal splints, 5 patients are less than 20 years of age, 19 patients are 20 to 29 years of age, 12 patients are between 30 to 39 years of age, greater than 40 years are 4 patients in group with intranasal splints. In group without nasal splints, less than 5 patients are included with less than 20 years of age group, 20 patients with age group of 20 to 29, 9 patients with 30 to 39 years, and no patients were included greater than 40 years. Patient.
Hello?
Ma'am, 1 second.
What happened? Continue.
Yes, ma'am. Patient count by gender, 15 patients were in group with intranasal splints, 15 patients were males, and 25 patients were females. The 1 second, ma'am. This ad is always popping up. In group without splints, 13 patients were males and 27 patients were females. Results post-operative outcome 1 week post-operatively. Patient count by post-operative outcomes. In group with intranasal splints, no patients were shown formation of adhesions or crustaceans, and no patients were shown any perforations. Crusting is seen in 2 patients. In group without splints, 10 patients showed adhesions, 20 patients showed crustaceans, and 1 patient showed perforation. Early postoperative outcome contrasted between the two included study groups. Patient count by postoperative pain levels. In group with intranasal splints, 5 patients showed mild and 10 patients showed moderate pain and 1 patient showed severe pain. In group without splints, 11 patients showed mild pain, 30 patients showed moderate pain, and 10 patients showed severe pain. Patient count by sleep disturbances. In group with intranasal splints, 5 patients showed mild sleep disturbances, 10 patients showed moderate sleep disturbances, 3 patients showed severe sleep disturbances. In group without splints, 15 patients showed mild sleep disturbances, 30 patients showed moderate sleep disturbances, and 20 patients showed severe sleep disturbances. Patient count by difficulty in food intake. 5 patients showed mild difficulty in food intake. 15 patients showed moderate difficulty in food intake. 5 patients showed severe difficulty in food intake. 15 in group without splints. 15 patients showed mild difficulty in food intake. 30 patients showed moderate difficulty in food intake, and 20 patients showed severe difficulty in food intake. Discussion. Our study showed decreased risk of adhesion between septum and turbinates in splint group, and nasal discomfort and sleep disturbances are less with splint group, whereas increased postoperative pain and sleep disturbances in nasal packing. Our study showed significant difference in rate of crustacean in splints group and increased crustacean in nasal packing group, and there is less chance of septal perforation in splints group and more chances of septal perforation in nasal packing group. Conclusion. Comparing the 2 different techniques and based on the results of the study, septal splint suturing will have better results to those from nasal packing group from crustacean and complication point of view. However, septal splint suturing results in less pain and discomfort for the patient. Based on these observations, the septal splint suturing technique is valid alternative to intranasal packing following septal surgery. These are my references, ma'am and sirs. Thank you.
Okay.
Okay.
Sriram, you said the
Ma'am.
regular nasal pack. What exactly you mean by regular nasal pack?
Ma'am,
The other
in
group
our
had
study,
regular nasal pack.
yes, ma'am. In our group, we used anterior nasal packing, with soaked in soframycin.
That is ribbon gauze.
Ribbon, yes, ma'am. Ribbon was soaked in soframycin.
Okay, why separation was seen in that group?
Ma'am,
What are the cause of perforation?
while during nasal packing, while packing with both nostrils, there was a little injury in one patient as we pack without blindly in the without vision. There was perforation in one case.
Okay. Yeah.
Okay, ma'am.
The-
Sir, Bharti
the-
madam, any more questions, madam?
No.
Thank you, madam. Can we proceed for the next speaker?
Yeah.
Our next speaker is, next presenter is Dr. Tummala Tejasvi. Are you ready, ma?
Yes, ma'am. Yes, ma'am.
Share your screen.
Projectors who have finished, please leave the group. Leave the link.
Dr. Tummala Tejasvi.
Ma'am, are you able to see my screen, ma'am?
No.
Only your face, not your screen.
Okay, sir.
Yeah, you can go ahead. Time.
Yes.
Sriharsha, start the
Yes, yes.
timer. Yeah, please.
1 second. Can I start, sir?
Yes, yes, you can start.
Good afternoon, sirs and moms. I'm Tumala Tejasvi. My case series on retrospective analysis of CSF rhinorrhea, diagnosis and management. Introduction: cerebrospinal fluid rhinorrhea results from a direct Cerebrospinal fluid results from a direct communication between the CSF containing subarachnoid space and mucocele space of the paranasal sinuses, because it may serve as a path for the spread of bacterial pathogens and other microorganisms. CSF rhinorrhea may lead to meningitis and intracranial infections, which carry significant morbidity if we don't treat in early time. Cerebrospinal fluid rhinorrhea may be classified as traumatic and non-traumatic. More than 90% of the cases will be traumatic and less than 10% are traumatic. Traumatic leaks occur in the setting of accidental trauma, neurological and rhinologic procedures. Non-traumatic CSF rhinorrhea etiology includes elevated intracranial pressure, neoplasms and hydrocephalus. Aim of my study is to analyze the clinical profile, diagnostic approaches, and management outcomes of the patients with CSF rhinorrhea in a tertiary care setting. Objectives of my study included to review the demographic and clinical profile of patients with CSF rhinorrhea, to evaluate diagnostic modalities used in identifying the site and cause of CSF leak, to analyze management strategies employed, including surgical and non-surgical approaches, to assess treatment outcomes, recurrence, and complications, to derive recommendation for optimizing diagnosis and management in a tertiary care setting. Materials and methods: I have included 6 consecutive patients diagnosed with CSF rhinorrhea who were evaluated, diagnosed, and management in tertiary care center between December 2024 to August 2025. My data collection was based on patient demography such as age, sex, clinical presentations, duration of symptoms, etiology and site of leak, diagnostic modalities used, management approach, postoperative care and complication outcomes. Data is analyzed based on demographic patterns, diagnostic yield, management outcomes, recurrence, and complications. My inclusion and exclusion criteria were all age groups and documented site of leak and complete medical records recovering presentation, diagnostics, management, and outcomes. Confirm CSF rhinorrhea by at least one of the following: radiological confirmation of skull-based defect or CSF fistula, intraoperative visualization of leak or defect, and minimum follow-up of more than or equal to 3 months. And my exclusion criteria was patients with uncertain diagnosis, cases with incomplete medical records, patients lost to follow-up, patients with non-nasal CSF leaks, patients managed conservatively at outside hospital, patients with associated intracranial infections requiring neurological intervention. And the investigations I did on all 6 patients were included. Biochemical tests were CSF analysis, and the radiological investigations were CT-PNA, CT cystoscopy, MR angiography, and HRCT. And about the management, I have managed all 6 patients both conservatively and surgically, and 5 out of my 6 patients were managed both conservatively and surgically, and 1 patient have been treated only conservatively. In conservative management, subarachnoid drainage through a lumbar catheter is done, which is done by radiologists. Strict bed rest, head and elevation was advised. Stool softness, patients are advised to cough, avoid cough, sneezing, nose blowing, and straining, and prophylactic antibiotics were given. On surgical management, all 5 patients of my case series were surgically managed by technique using endoscopic techniques. Endoscopically, CSF leak repair was done under general anesthesia. After surgical management, postoperative care included strict bed rest, antistaphylococcal antibiotics, a monitoring for intracranial complications, avoiding strenuous activities, sneezing and coughing. Nasal pack removal was done after a long period of surgery, and operative site has been checked with serial endoscopy. Next, I'll go through all the 6 cases quickly. My case 1 was 32-year-old female with diagnosis of non-traumatic CSF rhinorrhea. She was surgically managed with endoscopic leak repair, and the graft used was facial aorta. On postoperative complications, she had a headache. Then we have advised all the postoperative care as I mentioned above, and patient has been followed for 3 months and no recurrence was seen till date. And case 2 is a 32-year-old female with diagnosis of non-traumatic CSF rhinorrhea with neoplasm etiology. The neoplasmic tumor was meningocele, and the patient was surgically managed with endoscopic leak repair under general anesthesia, and the graft used was composite graft. There was no postoperative complication, and follow-up was done for 4 months, and no recurrence was noted. And case 3, 62-year-old female patient with clinical diagnosis of non-traumatic CSF rhinorrhea. She was also surgically managed with endoscopic technique, and the graft used was facial aorta, and the patient was followed for 6 months with no recurrence till date. And case 4 was a traumatic CSF rhinorrhea patient with a 32-year-old female. She surgically managed with graft use was PAT, Surgicel, and Tessel, and she was followed for 5 months with no recurrence till date. And case 5 is a 48-year-old female patient with spontaneous CSF rhinorrhea. Patient was managed with medical management and recovered with only medical management without any surgical intervention needed, and was discharged in stable condition. Patient was followed for 5 months, no recurrence till date. And the case 6 was a 9-year-old male patient with clinical diagnosis of non-traumatic CSF rhinorrhea with neoplasm etiology. He was surgically managed with endoscopic technique. Graft use was facial aorta, and patient was followed up for 8 months, no recurrence noted till date. All non-traumatic cases were given acetazolamide in medical management. Acetazolamide is a enzyme, carbonic anhydrase enzyme inhibitor. Its mechanism is to reduce transport of sodium and bicarbonates, which help my patients to decrease the CSF leak flow, promoted spontaneous closure in one of my patients, acts as a non-invasive supportive therapy to treat CSF rhinorrhea. Along with acetazolamide, proper position, stool softeners, and all were advised. And coming to my results, my case series population was 6 years, and the age range was between 9 to 65-year-old, and 90% of the non-traumatic CSF rhinorrhea were female and 10% were male. Traumatic 10% and non-traumatic cases were 90% of all 6 cases. And diagnostic modalities I used were CSF analysis for all 6 patients, and imaging used was CT-PNS, MR angiography, and HRCT in one traumatic CSF rhinorrhea patient. And coming to management, 1 out of 5 patients were conservatively managed with only medical management. 5 of them required both medical management and surgical management. Outcomes were recurrence was not noted
Time
till
is
date,
up.
but thank you.
Your time is up, Amma.
Okay.
Can we proceed to next speaker, Dr. M. Kirti?
Yeah.
Dr. M. Kirti?
Yes, ma'am. I am there.
Share your screen.
Madam, you specify the serial number also.
Serial number 19, Dr. M. Kirti. Share your screen, ma'am.
Yes, ma'am. I'm sharing.
Yes, go ahead.
Yes, yes. Good afternoon, everyone. I am presenting the case series of frontal and ethmoidal mucoceles with its orbital complications.
Continue.
Next slide, you go.
Start it. What's wrong? Is there any problem?
Yes, ma'am, slide is not working.
You have to share your laptop, not your screen. That's the problem. You see the option in the share, only your laptop.
Share your screen.
Introduction.
Yes. Start the timer, please. Harsha.
Already timer started, madam.
It's paused.
Mucoceles of paranasal sinuses are benign epithelial-lined mucus filled sacs occur due to the sinus outflow obstruction. Among all frontal mucoceles, being the predominant one due to its complex pathway, followed by ethmoids, maxillary, and sphenoid. Its prevalence varies geographically, but estimated at 0.4 to 0.6% of all paranasal sinus pathologies. They often present in adults from 3rd to 7th decade of life. Early recognition is clinically important as they can cause significant morbidity like mass effects, sinus expansions, thinning, and erosion of bone walls, leading to the nasal, orbital, and intracranial complications. Aims and objectives. My aim is to comprehensively categorize the patients with mucoceles with a clinical presentation, its radiological features, management, outcome of paranasal sinus mucoceles. Objectives. I include to analyze the demographic profile, anatomical distribution of paranasal sinus mucoceles, their clinical and imaging features, and to evaluate the complications and surgical management approach, and to assess the post-operative outcome. I did a prospective study and collected 5 cases during a period of 2022 to 2023 in our institute. A demographic profile includes age distribution and gender distribution. Among 5 patients, the frontal mucoceles are present in around 20 to 29 years of age group, followed by 4th, 5th, and 6th decades, and shows female preponderance. Based on sinus involvement, frontal mucoceles are more commonly involved than ethmoids. The clinical presentation among 5 patients are frontal headache, proptosis, medial canthus swelling, diplopia, and so on. Details of each cases. A 35-year-old female presented with a protrusion of right eye and frontal headache involving the right frontal sinus showing orbital complications. In imaging, erosion of light lamina papyracea was found and underwent endoscopic sinus surgery. The outcome was good with no recurrence rate and symptomatically improved. A 46-year-old female with left medial canthus swelling and foul-smelling nasal discharge involving the left frontal sinus have orbital complications, where the thinning of left lamina papyracea is identified and underwent endoscopic sinus surgery, where there is no recurrence on regular follow-ups. A 59-year-old female presented with a protrusion of left eye and frontal headache involving both left frontal and ethmoidal sinuses with orbital complications. There is a erosion of left lamina papyracea and frontal bone. Underwent a functional endoscopic sinus surgery with a fair outcome. A 28-year-old male patient with the right medial canthus swelling and diplopia involving the right ethmoidal sinuses with orbital complications. Here, the lesion is abutting and compressing the right medial rectus muscle, hence they presented a diplopia. Underwent a functional endoscopic sinus surgery and a marsupialization of agar assay was done with the symptomatically relieved after surgery. And the 5th patient presented with a nasal obstruction and frontal headache, where involving the right frontal sinus with both intracranial and orbital complications. Here, the erosion of right frontal wall posterior table is found. Therefore, the disease is spread to the brain, causing frontal lobe abscess. Therefore, the craniotomy was performed and the outcome is fair. Here a detailed presentation of a case of frontal mucocele. A 35-year-old female patient presented with a protrusion of right eye and frontal headache since 8 months. On examination, there is a proptosis of right eye noted, fullness in the medial canthus, and eyeball is pushed inferolaterally. On nasal endoscopy, fullness in roof of middle turbinate is noted. CECT PNS, paranasal sinuses, suggestive of expansile cystic lesion in the right frontal sinus, extending into the right orbit with erosion of lamina papyracea along the superior aspect of right orbit. Transnasal endoscopic approach, such surgical excision was done and the entire mucocele is exposed and drained, creating a large frontal opening into the nasal cavity to prevent recurrence. Here is a second case. A 28-year-old male presented with a swelling of right medial canthus and diplopia since 5 years. On nasal endoscopy, a bulge noted over lateral wall anterior to the uncinate. On MRI paranasal sinuses, a well-defined lesion abutting and compressing the anterior ethmoidal air cells, right medial rectus muscle, superior, and which gives differential diagnosis as dacrocystocele. Then we planned for dacrocystorhinostomy. On accessing the middle wall of the swelling, a pus dribbling is noted, which is followed by marsupialization of agar-nasae, where diagnosis was done perioperatively as ethmoidal mucocele, and anterior ethmoidectomy was performed. This series highlights among the 5 cases, frontal mucoceles as a predominant one because of its narrow drainage pathway, and there exists a diverse clinical spectrum of frontal and ethmoidal signs. Therefore, we need to correlate radiologically in both CT and MRI to rule out thinning and erosion of walls and to differentiate from other cystic lesions. Endoscopic sinus surgery is the current gold standard technique, and the patients presented with orbital complications underwent this surgery and symptomatically improved immediately after surgery with no recurrence for a period of 1 year. Recurrences for frontal and ethmoidal mucoceles is low, less than 10% is for a period of 1. This series emphasizes that timely recognition and minimally invasive procedure is done to reduce the morbidity and improves the outcome. My conclusion. This concludes early recognition, which is supported by high-resolution CT and MRI, are essential for accurate assessment of disease extent. Endoscopic sinus surgery is the treatment of choice, offering safe, minimally invasive drainage and restoration of sinus ventilation, therefore decreasing the recurrence and morbidity. Multidisciplinary collaboration from neurosurgeons and ophthalmologists are needed, and long-term follow-up, especially cases with complex orbital and cranial involvements, are present for optimal patient outcome. These are my references. Thank you.
Madam, are there any questions? Yes, ma'am.
Yeah.
Any question?
Kirti, you
Yes,
said
ma'am.
3-year study, but you said 3-year study, but it was written as 2023 to 2025.
Yes, ma'am.
It will not complete 3 study. And the second is, what is the direction of the orbital displacement? Is it different from frontal mucocele and the frontal ethmoidal mucocele or ethmoidal mucocele?
Yes, ma'am. Depending on the erosion of the bony walls and the involvement of the sinuses, from frontal, the erosion is mostly, if the erosion is involving the superior orbit of orbital wall, then the eyeball is pushed inferolaterally. For ethmoidal sinuses, if there is erosion from the medial side, so it is pushed outward.
Okay. Outward the displacement, lateral displacement.
Yes, lateral displacement is appreciated in ethmoidal.
Yeah. Okay.
Okay, ma'am. Next, madam. Our next participant is Saukya Teja. Saukya Teja. Number 20, madam.
Okay.
Serial number 20, Dr. Saukya Teja.
Yes, ma'am.
Share your screen.
Yes, ma'am. 1 second, ma'am. It's uploading, ma'am.
Yes, Sakya.
Yes, ma'am. Can I start, ma'am?
Yes,
Good
start.
afternoon, everyone. Today I'm going to discuss about management strategies of epistaxis with different etiologies. Coming to introduction, the epistaxis is one of the most frequently encountered emergencies in ENT practice. It is rarely pattern. About 90% of anterior bleeds occur at the epiciplar plexus. Posterior bleeds are commonly seen arising from the Woodrow plexus. Usually, there is a profuse bleeding with a difficulty in assessing the site of bleed and may lead to aspiration if not controlled. The posterior bleeds are seen commonly in patients with blood dyscrasias, vascular anomalies, hypertension, and patients on anticoagulant medications. To understand we have encountered 4 cases of epistaxis. So they are managed according to their etiologies. To understand magnitude of problem, we collected retrospective data from Jan 2024 to Jan 2025. We have seen the epistaxis more in males with age distribution of 61 to 80 years. Coming to case 1, she's a 37-year-old female patient with a known case of plasma thrombocythemia, undergoing repeated blood transfusions in hemato-oncology department, presented with the cold and epistaxis for 2 days. To control nasal bleeding, antifibrinolytic agents like injection tranexamic acid was given. Then emergency resuscitation was done with nasal packing. She was admitted for supportive care and management. As patient platelet count was low at the time of admission, she was transfused with 1 unit of single donor platelets and 6 units of random donor platelets. In spite of packing, we can see a mild bleeding from nasal cavity. So we have done CT angiogram to determine the source of bleeding. The CT angiogram showed no evidence of aneurysm or vascular malformations. So nasal pack removal was done in operation OT, and bleeding points were coagulated with bipolar, and nasal cavity is packed with the Surgisil. The patient was stable hemodynamically and was discharged. The CT angiogram, we can see the mild extravasation, the posterior to the left middle meatus. As the patient is a systemic cause, we have advised, we have counseled the patient for repeated transfusions, and also we have explained the local measures to control bleeding. It is a rare autosomal recessive condition in which there is defect in platelet membrane glycoprotein 2B and 3C, which affects the platelet aggregation. Coming to case 2, he is a 28-year-old male patient presented to the emergency department with massive bleeding from both nasal cavities for 2 days. Initially, he was taken to local hospital where anti-packing was done. Since bleeding was not controlled, he was referred to us. The patient had history of septoplasty and functional endoscopy 2 weeks back. He was asymptomatic for 2 weeks, but he had balls of bleeding after forceful sneezing. The CT angiogram revealed the pseudoaneurysm of the sphenoid artery. Digital subtraction angiography revealed a vascular blush originating from right internal maxillary and sphenoid arteries. The embolization of right internal maxillary artery was done with the polyvinyl alcohol particles. Hemostasis was achieved. Chemical coagulation of tiny beaters is done. Coming to case 3, I would like to discuss few points of case 2. It is a
It is a rare case. The patient is undergone phase. So post nitrogenic, he developed pseudoaneurysm of the left sphenoid artery. Here, this is as we can see a vascular blush originating from the left sphenoid artery, right sphenoid artery. The post embolization, we can see the resolution of the blush. Again, next time. The case coming to case 3, he is a 36-year-old male patient with no comorbidities, presented with complaints of bleeding from right nostril after forceful nose blowing for 6 hours. He was admitted and anti-nasal packing was done. As bleeding was profuse and not controlled with the nasal packing, CT angiography was advised. The angiogram revealed contrast extravasation from left sphenoid artery. Here we can see the extravasation of the contrast in the left maxillary sinus with hemosinus. Internal maxillary artery embolization was done, and also a cryoprecipitate transfusion was given in view of low fibrinogen count. The bleeding was controlled, nasal packing was removed, and patient got discharged. Coming to case 4, he is a 42-year-old male patient with a known case of hypertension and iron deficiency anemia. He presented with a high-grade fever with chills and cough for 10 days and bilateral nasal bleeding for 2 days. Anterior nasal packing was done in local hospital. As it's not controlled, he was referred to us. The patient coagulation profile was normal. CT scan of paranasal sinus with contrast was done. It showed hemosinus without any extravasation of the contrast. The nasal pack was removed. Bleeding was controlled with a bipolar cautery. Hypertension and anemia were corrected, and the patient was discharged. Coming to discussion, the cause of epistaxis can be categorized into local and systemic. Local causes include traumatic, infective, inflammatory, anatomical, climatic changes, foreign body, and neoplasms. The systemic causes include cardiovascular diseases, liver diseases, renal failure, and coagulopathies. Initial, the emergency resuscitation should be done. If vessel is vessel is identified, direct therapy can be done with the bipolar cautery. Vessel is not done, endoscopy should be done. Vessel is not located, indirect therapy with the anterior packing should be done. If bleeding is controlled, we can discharge the patient. If it's not controlled, you can continue with the posterior packing and septal surgery and ligation. If patient continues to bleed, we can advise angiography and embolization. And you have to check for any secondary factors. During angiography, embolization materials we use are coils, gel form, polyvinyl alcohol is used. The surgical methods include ligation of anterior or posterior ethmoidal arteries, internal maxillary arteries, sphenoid artery, and external carotid artery. Although complications of arterial embolization such as stroke, hemiplegia, ophthalmoplegia, facial nerve palsy, and soft tissue necrosis can occur, they are rare when procedure is performed by experienced hands. The embolization offers certain advantages over surgical ligation. It includes, it can be done in local anesthesia. It is less expensive and patient needs shorter hospital stay. However, both methods show comparable success rates and similar risk of major complications. Effective management of epistaxis require patient-centered approach. Consider not only severity but also consider different etiologies with individual risk factors. While nasal packing remains a cornerstone for initial control, interventional radiology techniques like embolization provide definitive treatment in refractory cases such as pseudoaneurysms and spontaneous artery bleeds. The patients with plasma thrombocythemia must be counseled for repeated platelet transfusion and local measures to control bleeding. The comprehensive strategy incorporating prompt diagnosis, supportive care, and follow-up is key to reduce recurrences. I would like to conclude my slide by telling the post-op septoplasty, the patient may have a pseudoaneurysm. So the possibility of pseudoaneurysm, we should exclude the possibility of pseudoaneurysms in pattern artery in post-surgery cases. Thank you. These are my few of the references.
Small submission for.
Can you switch on your video?
Yeah, yes.
Yes,
Without their video, we cannot take into consideration, madam. All presenters have to show their video. With the video only they have to present. Thank you.
Hello.
Hello, madam. Madam, is
Ah,
there any questions, ma'am?
Yeah. What embolization material they have used?
Ma'am, in this case, we have used polyvinyl alcohol.
Start your video, ma. Start your video. We cannot take this. Is like a proxy.
Your face video we want.
Ma'am, couldn't
Unmute your audio video.
unmute video, ma'am.
We want to see your face, ma.
Yes, ma'am.
Start video. There are options here down, start video. You start that.
Start video. I'm muted, ma'am.
Beside the mute button, mute and unmute button, you have a start video button. You have to start.
I have started, ma'am, actually.
No, video is stopped, yours. It's a temporary embolization material or a permanent embolization material?
It's a permanent.
Which is temporary embolization material?
Gel foam, ma'am. Gel foam, ma'am.
Okay, where we use it? In which condition, common condition of the nose we use that?
Hypertensive cases.
No, anything else? Where we do surgery afterwards? Okay, then I think we can go to the next student, I think.
Yes, ma'am. Our next participant is Dr. Deepa Shaivar. Dr. Deepa Shaivar, are you there? Dr. Deepa? Dr. Deepa, are you there? She's not logged in, I think.
Okay.
Go on to next candidate, madam.
Okay, our next candidate is Dr. L. Manisha Raj. Manisha Raj.
Manisha.
Dr. Manisha Raj. She is also not there. Dr. Amrita Gupta. Serial number 23, Dr. Amrita Gupta. Dr. Javeria Fatima. Dr. Javeria Fatima.
She is absent, madam. She declared initially.
He is also not there. Okay. Dr. Chinita Madhuri.
She is there. Yeah. Yes.
You
Dr.
unmute.
Deepa is taking the call. Dr. Javeria is absent. Dr.
Madam,
Chinta
our number.
Madhuri, which serial number? Please.
Am I audible?
25.
Yeah, you are
Serial
audible.
number
Share your
20.
screen, Madhuri.
Yes, sir. Yes.
Yes, Madhuri. Share your screen.
Yes, ma'am. Is my screen visible now?
Yes.
I'm starting now.
Yes, you can start.
Good afternoon, respected judges and faculty members and my PGs. Today, my topic for case series is Phases of the Black Fungus, a case series on diverse presentations of mucormycosis. To start with, rhinocerebroorbital mucormycosis presents an alarming public health challenge in India, with a prevalence estimated at 140 per million, roughly 80 times higher than that in developed countries. The condition is predominantly linked to uncontrolled diabetes, indiscriminate corticosteroid use, and environmental exposure, resulting in aggressive disease spread from paranasal sinuses to orbit and brain. Recent data shows a rising incidence with annual case rates varying from 18 to 89 per year in tertiary care centers across India, showing the increasing disease burden. This series reviews the clinical spectrum, incidence, and outcomes of rhinocerebroorbital mucormycosis, reflecting its clinical impact on affected Indian populations. The aim of the study is to analyze the clinical features, incidence, risk factors, management approaches, and outcomes of rhinocerebroorbital mucormycosis cases in patients presenting to our center. Objectives include to document demographic and clinical profiles of patients diagnosed with rhinocerebroorbital mucormycosis, to evaluate treatment strategies including surgical debridement and antifungal therapy, and to assess patient outcomes in terms of morbidity and mortality. This case series is of 15 patients admitted to our centers who were either diagnosed with mucormycosis or found to have the same later in the course of treatment. The data was recorded over a period of 12 months from January of 2024 to 2025. Majority of the cases were male patients. Out of 15, 11 were male and 4 were female patients. And the age demographic shows majority of the patients in 41 to 50 years of age group, and very few patients in extremes of age groups from 10 to 11 to 20 and over 61 years of age. The chief complaints that they were presenting with, majority of the patients had nasal obstruction and headache and cheek swelling. Cutaneous involvement was seen in 2 patients, cranial involvement in 1 patient, visual impairment was seen in 3 patients, and intracranial extension in 2 patients. All the patients had diabetic history. 4 patients had hypertension, 1 patient had hypothyroidism, and 1 had chronic kidney disease. To begin with a case, this is a case of a 44-year-old male patient who presented to OPD with chief complaints of nasal obstruction and discharge with blackish crusts for 15 days, cheek swelling for 5 days, and blackish discoloration over skin of lateral wall of nose for 2 days. He is a known case of diabetes and chronic kidney disease. Patient was started on amphotericin, which was given for 40 days. There was a long period before the surgery to bring his renal parameters and GRBS under control. After taking informed and written consent, we planned to reconstruct the skin that was being debrided with a laterally based forehead flap with the help of plastic surgeon assistance. Partial obturator was placed. Patient underwent FES with partial maxillectomy, inferior maxillectomy with flap reconstruction. The third picture is post-op on 15th day. The pedicle was cut 4 weeks after the surgery, and the last picture is 3 months after the surgery. Patient is on follow-up for 1 year. There is no complaints of recurrence, and the graft healed well. This is the case of a 28-year-old male patient who presented with complaints of nasal obstruction for 10 days, loss of vision which was sudden in onset and gradually progressive over 3 days, and skin involvement was seen for 3 days. He is also a known case of diabetes. Patient was on liposomal amphotericin for 20 days. Orbital exenteration was done because of there was complete loss of vision and there was intraorbital extension of disease. He's on a follow-up for 1 year, and the defect, there is a prosthesis was placed after orbital exenteration. There is no recurrence, and it healed well. The preoperative antifungals administered, out of the 15 patients, 11 patients were only on amphotericin. 2 patients were put only on posaconazole, and 2 patients were started induced with amphotericin and then continued on posaconazole. The drug-induced complications were seen with liquid complex or liposomal amphotericin B, which included hypokalemia in 7 patients, raised creatinine in 4 patients, and diarrhea in 1 patient. No side effects of posaconazole were seen. The duration of antifungals used and the dosage. The type of amphotericin used was either lipid complex or liposomal amphotericin B, which was started at a dose of 5 mg per kg and titrated according to renal parameters. Whenever there is a rise of creatinine or hypokalemia, the dose was decreased to reduce the complications. Posaconazole was started with a loading dose of 300 mg tablet twice a day on the first day, followed by 300 mg per day OD. The duration of amphotericin given 0 to 15 days was given in 2 patients, 16 to 30 days in 2 patients, 31 to 45 days in 4 patients, and more than 45 days in 3 patients. 2 patients were given a combination of amphotericin and posaconazole. The induction was done with amphotericin. 1 patient received amphotericin for 5 days, followed by posaconazole for 50 days. Another patient was induced with amphotericin for 8 days, followed by posaconazole for 60 days. And this includes both preoperative and postoperative antifungals. The surgical management given, 8 patients underwent only functional endoscopic sinus surgery. 3 patients underwent FES plus maxillectomy. 1 patient underwent FES with maxillectomy and orbital exenteration. 1 patient underwent FES with maxillectomy and flap reconstruction. In 2 cases, medical management was given. One of the patients died because of acute kidney injury with sepsis, and another patient was non-operable because of CV and multiple comorbidities. Outcomes: out of the 15 patients, 11 patients were, actually it's 12. 12 patients were discharged and on regular follow-up. 3 patients died. Pre-operative death was seen in 1 case due to acute kidney injury with sepsis. Post-operative death was seen in 2 cases. 1 case was due to cardiorespiratory failure and another case was due to worsening of general condition. Out of 3 cases of visual impairment, 2 cases had improvement of vision post-surgery and antifungal therapy. 1 case, orbital exenteration was done. Morbidity and mortality. In this case series, the mortality was 25%. The morbidity with mucormycosis includes complications such as blindness, cavernous sinus thrombosis, nerve damage, and cutaneous involvement. Maxillectomy leads to significant morbidity, including facial disfigurement, impaired swallowing and speech, pain, difficulty with diet consistency, and the quality of life is substantially affected. Though reconstruction techniques like free tissue transfer or obturators are used to improve functional outcomes, there are still partial sensory facial loss and neurological sequelae. So mucormycosis demands early diagnosis and prompt combined surgical and antifungal treatment. Posaconazole is a safe and effective alternative.
Your time is up, Madhuri.
Okay. Thank you.
Amrita Gupta, are you there? You have some technical issues in logging in. Amrita Gupta, I can see you in the participant list. Can you log in? Dr. Gunukula Sriram, can you leave the meeting, please? You have finished your talk. Can we go to next speaker, madam? Dr. Sharath Chandra B. Dr. Sharath Chandra B.
Ma'am,
Serial
I'm here,
number
ma'am.
26.
I'm here, ma'am.
Serial number 26, Dr. Sharath Chandra B.
Yes, ma'am, I'm here.
Share your screen. Share your screen.
Are you able to see, ma'am?
We can't see. Yes. Yes.
Are you able to see the presentation now, ma'am?
Yes, yes. Go ahead.
Good afternoon, respected ma'ams and sirs and my colleagues. Today I'm going to present a case of a rare case of sumatoid juvenile ossifying fibroma affecting the right maxilla in a 13-year-old patient. The aim of this presentation is to highlight the unique clinical, radiological, and pathological characteristics of the rare fibro-osseous lesion. We will discuss the surgical approaches used and the importance of early diagnosis and complete excision of this lesion. The patient is a 13-year-old girl who presented with the swelling of right side of her face in the right maxillary region. The patient's mother incidentally observed the swelling in the past 15 days. She brought her to the local known hospital where they have done a FNAC test of that swelling. They have came with this report of summatoid ossifying fibroma. When they came to the tertiary center, the swelling was unilateral and progressively enlarging. Clinical evaluation was followed by CT imaging, and excisional biopsy was done to establish the diagnosis. On examination, the patient had a facial asymmetry due to swelling on the right cheek, which was about 5 into 4 centimeters, which was firm on palpation and with normal underlying skin with no signs of inflammation or tenderness. It was obliterating the right nasolabial fold. Anterior rhinoscopy was normal, oral cavity was normal, hard palate was normal. Diagnostic nasal endoscopy was done, which showed minimal DNS to right, grade 1 adenoid hypertrophy, and also there was normal lateral wall of nose. There are no major abnormalities noted in the diagnostic nasal endoscopy, as you can see in this. Then CT scan, subsequently CT scan was done, which revealed a well-defined expansile hypertense lesion in the right maxilla. The lesion was which had mixed density with the distinct internal calcification, typical of that of somatic juvenile ossifying fibroma. We can see a growing lesion into the maxillary antrum, narrowing it. There is an evidence of cortical bone perforation with hello. Cortical bone perforation, which indicates the aggressive behavior of this disease, of the lesion. And subsequently, before this, pathological findings were seen. Seen here, where there is dense fibroblastic stroma with spherical ossicles, where histopathological examination showed the pathognometric sign of somatite juvenile ossifying fibroma. And surgical approach for this case was the lesion was completely excised with Culver-Lack approach through the maxilla under general anesthesia. The patient was supine under general anesthesia. Right-sided sublabial incision was given. Periosteum was elevated of the maxilla. Then cancerous bone, which was removed by scooping. Root of zygoma was drilled. And bleeders were drilled to obtain hemostasis. And drilling was done all around the cavity until we have seen the normal bone. Then, following which Surgicel was placed in the cavity. Romovac was also placed for proper drainage. The sublabial incision was closed with 2-0 Vicryl. This approach had permitted us to visualize the lesion in toto, and which helped us to completely remove the lesion. Postoperative diagnosis was confirmed with histopathological examination, where this HP report shows active juvenile ossifying fibroma, which was where in this condition the complete excision is crucial to prevent the recurrence. As you can see, the post-op case, pictures, the facial symmetry was restored. The patient was called for repeated follow-up to see for any evidence for recurrence. Her mother was she was happy after seeing the restoration of the facial symmetry for this case. Differential diagnosis of this case include fibrous dysplasia, central giant cell granuloma, ossifying fibroma, cemento-ossifying dysplasia, osteoblastoma, aneurysmal bone cyst, osteosarcoma, extracranial meningioma with somama bodies, and other fibrosis lesions, where distinct clinical presentation, radiological features, and histology with somama bodies have helped us to differentiate this somatite juvenile ossifying fibroma from other lesion. Now, when it comes to discussion in literature, somatite juvenile ossifying fibroma is a benign but locally aggressive fibroosseous neoplasm of the craniofacial skeleton with higher recurrence potential. Distinct from the conventional ossifying fibroma and fibrous dysplasia, there are two types noted. These are trabecular and or somatode, where somatode shows somoma like ossicles in cellular fibrous stroma. The sites include sinonasal complex and orbit. Jaw involvement is less common but is reported. The condition affects all ages, from infants to the older adults, according to literature. But while more common in children and young adults, the average onset can be either seen in late adolescence or early adulthood. There is no strong sex predilection. Overall, literature shows mixed trends. The sites include like 75% are seen in orbit or paranasal sinuses or skull. 25% are seen in maxilla, mandible, ethmoid or frontal. These are commonly involved. And when coming to conclusion, somamatide juvenile ossifying fibroma of maxilla is rare and can be locally but it can be locally aggressive. Early detection combined with a complete surgical excision, while using the Caldwell-Lack approach to maxilla, is essential to minimize the recurrence risk. This case highlights the importance of early diagnosis, management strategies, and also the need for long-term follow-up of such case. After completing this case, what I've seen in the literature is these are less common, but if they occur, they have high aggressive and may cause other symptoms. These are few references of mine. Thank you.
Okay. With the recurrence, does it have any malignancy tendency, Sharath?
In the literature, if the thing which has written is that after it is recurred, it has higher tendency. It has very little tendency to become malignant because it is just a proliferative disorder of cartilage and bone. But in literature, it has written both trends. Like it may become malignant, it may not become malignant, but the recurrence is much more common in this condition.
Radiologically, how do you differentiate between and from the physics of the maxilla? Radiologically.
Radiologically, when fibrous dysplasia of maxilla, it doesn't have a clear rim around it, but this somatode juvenile ossifying fibroma has a clear rim. It has a demarcation that shows its benign nature compared to that of fibrous dysplasia.
Fibrous dysplasia also is a benign. What other features will differentiate? Okay then.
Right.
Okay, madam. Can we go ahead, madam? Our next speaker is Dr. Komal Abhilasha. Before we go ahead, Dr. Amrita Gupta, are you ready? Dr. Amrita Gupta?
Yes, ma'am.
Yes, ma'am. Serial number 23. Be ready for the next. Be ready for the next. Now we are going for serial number 27. Dr. Komal Abhilasha. Dr. Komal Abhilasha. Serial number 27, Dr. Komal Abhilasha.
Yes, ma'am.
Yeah. Share your screen, please.
Yes, ma'am. Ma'am, can you see?
Yeah. Yeah, we can see your screen. Go ahead.
Yes, ma'am.
Keep it big screen.
My study is
Keep it big
Yes,
screen.
ma'am.
Keep it big screen.
Please turn on your video.
Big screen. Okay, ma'am. Ma'am.
And turn on your video, please.
Okay.
Start video and share your screen. Without your video, we cannot proceed.
Komal, are you
Yes,
using
ma'am.
laptop or mobile phone?
Komal?
Yes,
Komal
ma'am.
Abhirasha?
Starting.
You
Yes, ma'am.
share
Starting.
your laptop. Share your
We
laptop.
can't see your photo. Yes. Yes, go ahead.
Yes, ma'am. My study is correlation between radiologically identified stapes footplate thickening and pure tone audiometry findings in otosclerosis. Why are we doing this study? Otosclerosis is a progressive temporal bone dysplasia that affects selectively the aortic capsule and is characterized by excessive bone remodeling, bone desorption, and reactive bone deposition in the aortic capsule. Hallmark of this disease is stapes fixation and resultant conductive hearing loss. The diagnosis is frequently made using audiometric results and clinical suspicion, and temporal bone HRCT is the preferred imaging approach. So, in this study, we will correlate the footplate thickening with pure tone audiometric finding in cases of otosclerosis. So the objective of this study is to determine if high resolution computed tomography HRCT imaging advances to the audiological findings in the diagnosis of otosclerosis. So this is the retrospective case series, ma'am. The sample size is 50 patients. That means 100 years, and the duration of study is June 2025 to June 2024 to June 2025. Age group is 18 to 50 years. Inclusion criteria is 18 to 50 years at the time of age is 18 to 50 years at the time of pure tone audiometry. Clinical record consistent with suspected otosclerosis, gradual hearing loss with intact tympanic membrane documented. PTA done less than 14 days of HRCT imaging. Available HRCT temporal bone 0.5 sections of adequate quality, showing stapes fluid plate clear enough to identify fenestral otosclerosis
Komal,
and or.
please share your slideshow.
Yes, sir.
Slideshow. Start slideshow.
Slideshow. Yes, sir. Identify the available HRCT temporal bone of 0.5 mm sections of adequate quality, showing stapes foot plates clear enough to identify fenestral otosclerosis and or measure foot plate thickness or record presence or absence of thickening. Available PTA, AC and BC at air conduction and bone conduction at 500, 1000, 2000 and 4 kHz. No prior history of ear surgery. Exclusion criteria is less than 18 years to more than 50 years of age, and HRCT of insufficient quality or inability to visualize or measure footplate. Missing essential audiometric data to compute airborne gap or bone conduction required to measure audiometric data. Other middle ear disease documented. Prior history of otologic surgery in the study year. Other non-sclerotic causes of conductive or mixed hearing loss, systemic bone diseases affecting aortic capsule. This study consists of 50 individuals with diagnosed otosclerosis, of which 18 have unilaterally and 32 have bilaterally, for a total of 82 afflicted years. They were classified into two groups. Group A is early otosclerosis, involved 48 years, and Group B, late otosclerosis, involved 34 years. Hearing loss less than 2 years is considered as early otosclerosis, and hearing loss more than 2 years is late otosclerosis. Radiological evaluation, archived HRCT temporal bone scans.
I think you
Keep it
not.
Your screen is not moving.
Yes, ma'am.
Komal
Your
Abhirasha,
slide is not changing.
you share your desktop or laptop completely, not your PPT. Don't share PPT. Entire screen you have to share. Then you start slideshow. Got it?
Sir.
The share option, you share entire desktop or your laptop screen, complete screen.
Make your screen slideshow first.
Yes, sir.
No. Nothing is moving here, ma'am. Stop sharing and again share entire desktop, complete screen.
Okay, sir.
Then you start your PPT.
Don't worry, your timer is stopped. You can start again. You start from whichever slide you have done now.
Ma'am, can you see full screen, ma'am?
No.
One more minute is added to you actually.
Can you see full screen, ma'am, now?
No.
The slideshow, you know, no?
I'll help you out.
That
You
symbol
just,
is there.
Yes, sir.
Click
Stop
on
your,
that.
stop your screen share for a minute. Now
Yes, sir.
click share
Stop.
again. What do you see when you click
Share.
share?
In the
What do
share,
you see?
two options.
Share.
What
options do you see now? Once you click
Entire
share.
screen should I share, sir?
Yeah, do that.
Entire screen, sir?
Yes.
Sir?
Yeah.
Can
now
you
you
see
can
full
go.
screen, sir?
Yeah, you can go ahead.
Yes.
Exclusion criteria is age less than 18 years and more than 50 years. HRCT of insufficient quality or inability to visualize on major footplate. Missing essential audiometric data to compute airborne gap 0.5 to 4 kHz or bone conduction required to measure audiometric data. Other middle ear disease documented. Prior history of otologic surgery in the study year. Other non-sclerotic causes of conductive or mixed hearing loss. Systemic bone diseases affecting otic capsule. Any history of these are excluded from the case series. This study consists of 50 individuals with diagnosed otosclerosis, of which 18 have unilaterally and 32 have bilaterally, for a total of 82 afflicted years. They were classified into two subgroups. Group A, early otosclerosis, involved 48 years, and Group B, late otosclerosis, involved 34 years. Hearing loss less than 2 years is considered as early otosclerosis, and hearing loss more than 2 years is considered as late otosclerosis. Radiological evaluation, archived HRCT temporal bone scans were reviewed, less than 0.5 mm of thickness, focused to measure stapes footplate region and facial antefenestrum, recorded presence or absence thickness in millimeter, and two blinded radiologists or ENT surgeons measured independently. Audiological evaluation, GSI paleoaudiometer, IP30 air conduction earphone, and B81 bone conduction earphones were used. Collected PTA data is less than 14 days of HRCT temporal bone. Exact ear conduction and bone conduction thresholds are measured at 500, 1000, 2000, and 4 kHz. Calculated mean earbone gap and noted the presence of Cahart's notch, that is more than 10 decibel dip at 2 kHz. Statistical analysis. The analysis were carried out using the statistical software SPSS version 23. Descriptive statistics such as mean standard deviation and frequency and correlation coefficients were calculated for each measure. Pair t-test was used to compare the two groups. P-values were ascertained by applying corresponding persons correlation test, one sample t-test, and Wilson test as needed. A statistically significant level was defined as P less than 0.05. The presence of Cahart notch 2 kHz deep and its association with footplate thickness was tested using Fisher's exact test. Results: air conduction threshold showed elevation in the late otosclerosis group than in the early otosclerosis group, that is P less than 0.001, and bone conduction threshold showed more elevation in late otosclerosis group. Airborne gap was increased in late than early, that is P less than 0.001. Air conduction done from 250 to 8000 Hz, while bone conduction done only for 500 to 4000 Hz. The result of several audiometric tests were contrasted with the footplate thickening result from the CT scan. Results were the mean footplate thickness was 0.80 mm, ranging from 0.5 mm to 1.2 mm. Mean airborne gap was 33.47 decibels, plus minus 9.35 standard deviation, ranging from 25.5 to 42 decibel. Stapes footplate thickness showed a significant positive correlation with the magnitude of airborne gap. R is 0.93 and P is less than 0.03. Cahart's notch 2 kHz was present in 60% of cases and was significantly associated with increased footplate thickness. The sensitivity of Cahart's notch in predicting radiologically confirmed stapes fixation was 85% when combined with HRCT findings. Footplate thickness significantly correlates with the mean of 36.8 decibel and 66.5 decibel in air conduction in early and late otosclerosis respectively, with P equal to 0.002 and mean of 11.3 decibel and 24.5 decibel in bone conduction in early and late otosclerosis respectively. P is equal to 0.004 with a significant of airborne gap 25.5 and 42.0 decibel in the early and late otosclerosis respectively. Inference is increasing footplate thickness leads to greater conductive hearing loss, that is larger airborne gap, and Cahart's notch is reliable clinical marker, but its predictive value improves when combined with radiology, HRCT. Correlation analysis confirms that the radiological severity footplate
Your
thickness
time
matches
is up.
with the...
Your time is up,
Okay, ma'am.
Abhilasha.
Okay, ma'am.
Dr. Amrita Gupta. Dr. Amrita Gupta, are you ready? Dr. Amrita Gupta.
Her number?
Serial number 23, madam. She missed because of technical issues. We are going back to 23. Amrita Gupta, share your screen. Serial number 23, Dr. Amrita Gupta. Share your screen. And video also. Camera. Yes, Amrita. Any problem? We'll come back to you again. We'll go to the next speaker. We'll go to the next speaker, Dr. Ramya Sri. Dr. K. Ramya Sri. Dr. K. Ramya Sri, are you ready? Dr. Amrita Gupta, we'll come back to you again. Amrita? Dr. Ramya? Dr. Ramya Sri, are you ready? Dr. Sana Noori?
Yes,
are you
ma'am.
ready?
Yes, ma'am.
Serial number 29, Dr. Sana Noori. Dr. Sana Noorin.
Yes, ma'am.
Share your
Yes,
screen.
ma'am. Oh, this is not mine, ma'am.
Yes, ma'am.
Then who's
Video
this?
is on, ma'am.
Is this?
Am I visible, ma'am?
Yes. Share your screen, Sana.
Ma'am, is my screen visible, ma'am?
Yes.
Ma'am, that is not me talking.
Sana Noori, what's your number?
29, sir.
Madam, serial number 29, Dr. Sana Noreen.
Yes, ma'am.
Yeah. The screen is here. We want to see your video.
Yeah,
Ma'am,
she's
my
there only.
video is-
Yeah, okay. Okay.
Shall I
Go
start,
ahead.
ma'am?
Yeah, go
Good
ahead.
afternoon, everyone. My name is Dr. Sana Nuri, and my topic of series presentation is study of bacterial flora from superficial and core tissues of tonsils in chronic tonsillitis. Tonsils is a paired lymphoid tissue present in the tonsillar fossa. It is lined by non-keratinizing stratified squamous epithelium underlying lymphoid follicles with germinal centers. The medial surface faces oropharynx and the lateral surface has fibrous capsule, peritonsillar space, superior constrictor muscle, and parapharyngeal space. It is part of Voldier's ring and peak activity seen in childhood, and it involutes after puberty. It produces IgG and IgA antibodies. It is the first line of defense in oropharyngeal infections and gives humoral and cell-mediated immunity. The common commensals seen are staphylococci, streptococci, anaerobes, bacillus, and yeast. The difference between tonsillar organisms and the organisms present in oropharynx is there are more number of anaerobes in the tonsils because of the crypts. The anatomical supply of the palatine tonsil, arterial supply is by branches of external carotid artery, venous supply is by internal jugular vein, nerve supply is by glossopharyngeal nerve, and lymphatics drain into jugular digastric node. Chronic tonsillitis is the chronic inflammation of palatine tonsils, which occurs as a result of repeated attacks of acute tonsillitis or due to inadequately resolved acute tonsillitis. It mostly affects children and young adults. They usually present to the OP with sore throat, fever, pain or difficulty in swallowing, cough, halitosis, etc. Treatment includes medical and surgical management in few cases. The aim of the case series is to study bacterial flora from both superficial and core tonsillar tissues in chronic tonsillitis. The objectives are to isolate and identify bacteria from tonsillar surface and core, evaluate the limitations of the surface swab cultures, and to identify relevant antibiotic therapy for tonsillitis treatment. The materials and methods. 60 patients who came to our institute with chronic tonsillitis were operated for tonsillectomy by dissection and snare method. Detailed history was taken and a complete clinical examination with special focus on throat and neck were done. Investigations both for surgical fitness and chronic tonsillitis in form of hematological investigations and cultural sensitivity of the throat swab taken from tonsillar surface. Intraoperatively, once the tonsils are excised, a cut is given with sterile blade into each tonsil and another swab from core tissue of the tonsils were taken. They were labeled right and left and sent for culture and sensitivity. The results obtained showed in the superficial swab, 46.7% of the cases showed coagulase negative staphylococci, followed by no growth in about 40% of the cases. Less than 10% of the cases also showed Corynebacterium and Streptococcus. Whereas the organisms seen in the right and left core were gram-negative bacilli like Klebsiella E. coli, coagulase negative staphylococci, and gram-positive cocci like Streptococcus viridans. There were certain organisms present in just right tonsil while absent in the left core of the tonsil. These included Pseudomonas and mixed flora. The sensitivity to antibiotics, vancomycin showed the highest sensitivity, followed by linezolid, imipenem, and the least sensitivity was seen in ciprofloxacin and penicillin. Whereas the highest resistance was shown in penicillin, followed by ciprofloxacin, azithromycin, ceftriaxone, and amoxiclav. To discuss, the superficial swab often contains commensals, but they become pathogenic sometimes either due to altered flora or increased infection load. The common organisms seen in the superficial swabs are Staphylococcus coagulase negative, Streptococcus, Corynebacteria. whereas the core cultures yields true pathogens and are more reliable isolates. The common organisms seen are Staphylococcus aureus, Streptococcus pyogenes, Haemophilus influenza, and anaerobes. Evidence from literature published in 2023 March in Indian J Medical Microbiology showed Pseudomonas aeruginosa as most commonly reported organism in both surface and core swab cultures, whereas the study published in Indian J Otolaryngology Head and Neck Surgery this year, done on adenotonsillitis patients, showed Streptococcus and Enterococcus being the most common pathogens susceptible to ciprofloxacin. My findings are in agreement with the other two studies in showing that organisms cultured from surface and core were not identical, and their antibiotic sensitivity patterns also differed. Although the specific organisms varied across the three studies, all highlighted a clear difference between surface and core flora, as well as in the drug response. The core cultures help in guiding better for antibiotic therapy. The presence of anaerobes and resistant flora may require the need for broad or targeted antibiotics, whereas tonsillectomy remains the definitive treatment in recurrent or refractory cases. To summarize, analysis of 60 patients reveals the bacteriology of superficial swabs differ significantly from that of tonsil core cultures. While cons and streptococcus were isolated from both sides, gram-negative bacilli and pseudomonas were isolated from the core, highlighting the limitation of throat swab and representing deeper infections. Antibiotic sensitivity showed high sensitivity, almost 100%, for vancomycin and linezolid. Clindamycin, ceftriaxone, amoxiclav, aminoglycosides, and carbapenems had 70% efficacy, whereas ciprofloxacin and azithromycin had moderate sensitivity, and there was high resistance with penicillin. I conclude my study with findings suggesting that surface and core cultures are not identical, and relying solely on throat swabs for culture may lead to misinterpretation of the pathogenic organisms and the resistant profile. Empirical treatment should therefore avoid penicillin and instead consider clindamycin, ceftriaxone, or amoxicillin, with vancomycin linezolid reserved for resistant cases. Tailoring antibiotic therapy for chronic tonsillitis based on core cultures. Since this treatment was, this study is based on 60 patients, and it's still an ongoing study, we are still trying to incorporate broader spectrum of patients so as to get a definitive idea and to avoid antibiotic resistance in the patients. Thank you.
Okay.
Yeah.
Ma'am, any questions? Sir, Ravi
Sana,
sir.
with your study,
Madam.
Sir, Ravi sir,
can
is
we,
your
Madam, please
you
wait.
know,
Bharti madam asking questions, please. Ma'am, go ahead.
yes,
Sana,
madam. Yes,
with
madam.
your
Go ahead.
study,
Yes, ma'am. Sorry.
like ongoing study, can we totally abort tonsillectomy? Like, can
No,
we give
ma'am.
antibiotic? In the sense, can we, like, you know, just give the antibiotic, like you do the core, sometimes can we do the core biopsies and take culture sensitivity and give only that rather than doing tonsillectomy? What was the purpose of doing
Yes,
this
ma'am.
study?
Ma'am,
What is the
it
purpose?
helps to determine to determine the antibiotic sensitivity, and also in cases of recurrent infection, sometimes the organisms over the superficial are different compared to the
Yeah, it's
core.
all known, like we all know, like last 40 years we all know that. So what was the purpose of doing this study? Anything like, can we totally avoid doing tonsillectomy by addressing the core organism, something like that? For that you did, or changing trend you wanted to know?
changing trend I wanted to know, because there are increased cases of resistance in commonly used drugs like amoxiclav, ciprofloxacin, or third generation cephalosporins. And if we do FNAC or something like that for determining the organisms, then we will not get proper tissues. So we might not able to culture the organisms properly.
Okay.
Shall I stop?
Sir, Ravi sir,
Madam.
sir, are you connect your sir?
Yes, yes. Tell me, ma'am.
I just want to know, because you have put in your chat your audio is not coming. So are you able to?
Yes.
No, sir, you are not audible.
Okay. May I?
Yes,
Tell
sir.
me, madam. Yeah, tell me. I'm audible, madam. You tell me.
Ravi sir. Our second judge, Dr. Ravi sir, his voice is not audible. Sir is trying to ask questions. Sir, voice is not audible. Harsha, can you help? Sriharsha?
Okay, ma'am. I'll see.
Sir has put in the chat box long time before. Sir is trying to communicate, but we can't hear his voice.
Some issue from sir side only, ma'am. We will try to check.
Huh, sir.
Meanwhile, we can
Can you
move on.
call sir? Can you call sir?
Yeah, please. Okay.
Yeah.
Sir, shall I stop screen sharing?
Ma'am, Bharti madam, any more questions, ma'am? Can we go ahead with the other speaker? Bharti madam? Our next speaker,
Go,
had some technical before Dr. K. Ramya Shri. Yes, Sana, you can close your screen. Dr. K. Ramya Shri. Ramya Shri, are you ready? Yes, but we can't see your screen. Share your screen. No, we can't see. Huh.
Can you see me?
We can see your screen, but we can't see your video. Where are you?
Hello.
Serial number 28, Dr. K. Ramya Sri.
Ma'am, can you see? Ma'am?
We can see your screen, but we can't see your video. Start video.
Ma'am, how can?
Huh?
Now can you see?
No.
Now?
No, we can't see you.
Ravi sir, you can talk now.
No.
Okay.
Can you see?
We can't see your video, ma'am. Ramya Sri, your screen is visible, but we can't see your face.
Ma'am, no can you see? Yeah.
No.
Ma'am?
Hello. Yeah, Dr. Ravi, we can hear you. Dr. Ramya, we need to see your video, your photo. We are seeing your sharing content, Ramya.
Video is on.
No, we need to see you. We are seeing your sharing PPT.
How much?
No, not able to see. That video symbol will be there. No, you click on that.
Ramya, click on start video.
I think you should give some proper instructions before to them. Maybe 1, 2, 3, 4 number. What to do?
Yeah, we have already given, sir, 2 to 3 days trial run also we have done. Some people attended, some people neglected. That is the problem, sir. See, every time we are running the trial run, sir.
Okay, sir.
Whoever are
Since
interested,
yesterday the
can
trial
start.
run is on. Sir, since yesterday the trial run was on.
Okay.
Only few people had done.
No, where are they doing presentation? The presentation that they are doing from their home or from some medical college? Where they are presenting from?
Both ways, sir. Some of them are sitting at their home. Some of them are doing from the college.
Okay.
Ramya, we can't see you. Unless we see you, we can't proceed. We'll come back.
Ramya,
Video is
are you using your mobile phone or laptop?
Laptop, sir. Video online.
Where are you sitting, in a Wi-Fi room?
That is the
Mobile
that is the problem. You have to use good speed Wi-Fi. We informed it repeatedly, no? Meanwhile, madam, you call in any other candidates?
We have one more participant, Dr. Amrita Gupta. Is she here?
Over, madam.
Yes,
Amrita
ma'am.
Gupta. Presented. Any other?
Ma'am,
Am I?
Yes, ma'am.
Yeah, she presented. Yeah. Nobody else?
Hello, ma'am. I did not present, ma'am, yet.
Number 23, she is not presented.
Amrita Gupta can present. Amrita Gupta 23.
23.
Dr. Amrita Gupta not yet done.
Yeah, our number is
Are you
23.
ready? Number 23. Are you ready?
Yes, ma'am.
Amrita Gupta.
Share your screen.
Share your screen.
Is my screen visible?
No.
No.
Ramesh's screen is coming
Dr. Rameshri, you stop sharing. Then only others will share their screen. Ramya. Dr. Rameshri.
Dr. Ramyasri.
Yeah. Amrita, you can share your screen.
No.
No, ma.
Is it visible now, sir?
No.
When you share your entire screen. Don't click the application if you have issues. Stop your screen and click share entire screen.
Dr. Amrita, now you can start sharing entire screen.
Yes, sir.
Keep your screen in slide share and start share.
Hello, ma'am.
No. No, ma.
Amrita, are you at hostel? You can
Yes,
use
sir.
your you can use your any other colleague's laptop. No, ma.
Dr. Ramyasri, can you go to your department if you are there in the hostel, or share with, go to a Wi-Fi room and try again? Ramyasri and Amrita, you can also share from your friend's laptop. We can't. We can see you, but we can't see your screen. Where are you sitting? Hostel or department? Wi-Fi room?
Is the screen visible now, ma'am?
No.
You can call next candidate Sana Noori.
Sana Noori is over, sir.
Over. Okay. It's
Over. Everybody is over. Only Amrita Gupta and Ramya Sri are remaining. Both of them are facing technical issues.
Yeah, Amrita
Yes,
Gupta,
Amrita is.
you are here. Okay.
Yes.
You can carry
Yes,
on.
we can see you, ma'am. Yes.
Yes, ma'am. Can I start? Am I audible?
Yeah, go ahead, go ahead.
Yes, go ahead.
The video is gone.
Good afternoon, everybody, esteemed judges and faculties. Today, I'll be presenting a case series on the orbital complications of fungal sinusitis. So as we all know, fungal sinusitis in itself is a very vast and notorious disease. And due to the proximity of the paranasal sinuses to the orbit, creates a pathway for it to extend into the orbital space and even intracranial space, causing permanent visual loss, cavernous sinus thrombosis. So the objectives of my case series is to present 3 cases of orbital complications occurring secondary to otitis, the radiological findings and the management approaches used in these patients, and also to analyze the treatment outcomes and highlight the importance of early multidisciplinary intervention. This is a case series conducted in the Department of ENT spanning over a period of 8 months. We took 3 cases of fungal sinusitis with orbital complications. We observed the clinical presentation, the risk factors, and radiological findings associated with the cases. Management strategies opted for these patients and observed the treatment outcomes. All of our 3 cases occurred in mid as the primary predisposing factors. 2 patients had additional risk factors, one with HbA1c positive status and another with hypertension.
So what basically is the pathogenesis behind the invasive fungal sinusitis? Any condition predisposing us to immunosuppression, be it patients on steroids or immunosuppressant drugs, such as organ transplant recipients, patients with diabetes, HIV, patients on chemotherapy, which can lead to neutropenia, and patients of iron overload on desferrioxamine therapy. All these conditions predispose the patients to immunosuppression and promote the growth of the fungus. Further, the inhaled fungus grows and invades the structures, causing thrombosis of the blood vessels with their characteristic angioinvasion property, causes mucosal necrosis and loss of sensation. Also, this mucosal necrosis creates an acidotic environment for the fungus to grow, promoting the bony destruction, perineural spread, and the perivascular spread, which is responsible. This is a first case of acute invasive fungal sinusitis with panophthalmitis and cavernous sinus thrombosis. 52 years male with uncontrolled diabetes and hypertension, presenting with symptoms of complete closure of eye, pain, and loss of vision in right eye. As we can observe, there is complete closure of the right eye. There is proptosis, chemosis, and there was also ophthalmoplegia on examination and loss of perception of light.
Slide is not changing. Only first slide is seen. Materials method slide is being seen.
Hello, sir. Am I audible?
Yeah, carry on.
Carry on.
Yeah, carry on.
Continue, my timer is going.
On diagnostic nasal endoscopy, we could see crusting present in the middle meatal and the superior turbinate region. This is the crusting we saw in the diagnosis. On radiological investigations, we can see hyperdense soft tissue lesion in the right maxillary sinus, eroding the medial wall of the right orbit and extending into the extracorneal space of the right orbit. The patient was managed with a combined surgical and medical approach with endoscopic debridement and IV liposomal amphotericin B. Second case is a case of allergic fungal rhinosinusitis with orbital cellulitis. 55 years male with HBS AG positive status, blood tinged nasal discharge from right nasal cavity, and double vision in right eye with blurring of vision. The patient has past history of sinus surgery done twice previously also. On radiological investigations, we can see the hyper lesions in bilateral maxillary sinuses extending into the bilateral ethmoid and the frontal region, causing erosion of the bilateral medial wall of the bilateral orbits and extending into the extracorneal space. This patient was also managed with a combined surgical and medical approach with systemic antifungals. A third case is a case of invasive fungal sinusitis with both intraorbital and intracranial extensions. 32 years male with diabetes, uncontrolled, presenting with complaints of bilateral nasal obstruction, proptosis, and blurring of vision in both eyes. On radiological examination, you can see hyperdense soft tissue lesion in the sphenoid sinuses, ethmoid sinuses, and the frontal sinuses, eroding the cribriform plate and extending into the intracranial space. Here also we can see the involvement of bilateral maxillary sinus, ethmoid, and frontal sinus into the bilateral orbits, eroding the lamina papyracea. And this is the MRI showing a T2 hypointense lesion causing erosion of the superior ending into the intracranial space. This is the intraoperative picture showing fungal debris in the sphenoid sinus. This patient was also managed with a combined medical and surgical approach. So the most commonly used antifungal, which is amphotericin B, what is the mechanism of action behind it? It is derived from the Streptomyces nodosus, administered through an IV route, and it basically micropore in the fungal cell membrane, leading to the leakage of contents from the inside of the fungal cell into the exterior environment. It is given in a dose of 5 to 10 milligram per kg per day. So at last, all three cases were managed with endoscopic sinus surgery and amphotericin But what varied were the outcomes? First case had no visual recovery. The second case had partial visual recovery. And in third case, the vision was preserved. So discussion. Orbital involvement is seen 22% of invasive fungal sinusitis cases, more so in patients already predisposed with risk factors such as diabetes and immunosuppressed cases. Surgical and medical management both form the mainstay of the treatment. Surgically, we should immediately clear the sinuses of all the fungal debris, and antifungals, mainly the IV liposomal amphotericin B, should be started even before the histopathological reports have confirmed the specific fungus. The debridement will lead to slowing of the progression of the disease, and also will create a space for better space for action of the systemic and the topical antifungals. So orbital signs should be treated as red flags in patients of fungal sinusitis. Outcomes vary mainly because the earlier we treat the patient, the better we have the outcomes. Delay lead to irreversible blindness and intracranial applications. The modern management strategies emphasize conservative but thorough debridement. Pathogen-specific antifungal selection is very important. And multidisciplinary collaboration between otolaryngologists with radiologists and ophthalmologists is essential for optimal care and management. These are some of my references. Thank you.
How many days did you give antifungal therapy, amphotericin B?
Yes, sir.
How many days, how many weeks did you give this amphotericin B?
Sir,
only 1 week?
Yes, sir. 1 week to 10 days.
That's it.
What
After that?
dosage? What dosage?
Ma'am, 5 to 10 milligram per kg per day is given in all patients, ma'am, with a daily renal function test monitoring, ma'am.
When do you stop the treatment? What is the indication to stop the medical line of management?
Ma'am, daily systematic improvement and examination, ma'am. When the patient is getting like in cases of orbital complications, when observe the visual recovery to be getting back, then we can stop the treatment, ma'am.
Okay.
I don't think that is the criteria. Just refer. Okay.
Yes, ma'am.
Ma'am, Dr. Ramya Sri is ready. Can we call her?
Yes, yes.
What's the number? Ramya number?
28. Serial number 28, ma'am. Dr.
Okay.
K. Ramya Sri.
Ma'am, can you hear me?
Yes.
You. Little
We
loud.
can hear
Be
you,
little
but
loud.
we want your. Yes, start your screen.
1 second.
Amrita, close your screen. Stop sharing, Amrita.
No, Ramesh has shared already, but she has to go
This
to
is
the
your
first
screen,
slide.
Ramya. 1 second, ma'am.
Yes,
Go to
Ramya.
the first slide.
Go to first slide.
Wait. 1
Start
second.
presentation at the beginning.
Start from beginning, Ramya Sri.
Ma'am, I will start from the hospital.
Start your first
Ma'am,
page. Yes.
Yes, start.
Timer start.
Good afternoon, sir. My topic is respiratory papillomatosis clinical. caused by human papillomavirus type 6 and 1. Although histologically benign, possibility of morbidity due to airway obstruction, frequent recurrence, and the risk of malignant transformation. Both juvenile onset and adult onset forms have been reported, each with variable clinical causes. A. Analyze the clinical presentation, management, and outcomes of patients with respiratory papillomatosis treated in a tertiary hospital. Objectives are to study the clinical patients diagnosed with respiratory papillomatosis, to describe the operative procedure, and to assess the recurrence, and to emphasize the role of adjuvant therapy. Materials and method. The retrospective analysis was conducted on 3 patients diagnosed with histological confirmed respiratory papillomatosis at our hospital. Inclusion criteria includes all the age groups, patients who give informed consent, and confirmed histopathologically respiratory papillomatosis. Exclusion criteria: all patients who are not willing for surgery, and patients with malignancy or other glottic pathology. Patient 1 presented with a papillomatous growth involving the glottis. Involving the glottis can't visualize the vocal cosmer. Second patient, papillomatous growth involving the anterior 1/3 of the left vocal quadrant. Third patient, involving the anterior 1/3. All 3 patients presented diagnosis of voice airway obstructions, findings of concomitant video laryngoscopy. Anesthesia. General anesthesia patient position prepared with neck extended Gauss Jackson position. Under 0° endoscopic guidance, findings were noted. Papillomatous growth visualized. Debridement assisted exposition of papillomatous lesions performed. Adjuvant intravascular and intravenous bevacizumab was administered to reduce the recurrence risk. This is intraoperative video of debridement assisted exposition. Injection slowly. During post-operative care, distribution is done once the airway is stable. Voice test. Voice test is advised. Steroids are danger edema. Follow-up includes video laryngoscopy. Post-operative edema. There is no growth visualized. First patient map. This is total 3 patients. Presentation of hoarseness of pulse and airway obstruction. Relief achieved post-surgery. Recurrence observed in 1 case. Repeated excision required. Adjuvant bevacizumab helped reduce recurrence severity. Discussion. Disease nature respiratory papillomatosis is benign but highly recurrent, leading to significant morbidity. Etiology. Strong association with HPV type 6 and 11. Juvenile onset linked to vertical transmission. Adult onset by sexual transmission. Clinical changes, progressive hoarseness and airway obstruction, can extend to trachea bronchi in severe cases. Risk of malignant transformation. Adjuvant therapy, international and intravenous bevacizumab. Quality of life impact, voice change, and future surgeries.
Calculation respiratory papillomavirus is rare but resulted in benign airway disease. Early diagnosis and regular follow-up are essential for preventing complications. Medically, surgical excision remains mainstay of treatment. Adjuvant therapy is said to reduce recurrence and improve disease control. Thank you.
Okay, Dr. Ramya. Sir, Ravi sir.
Yeah,
Share your answer.
what do you do for the recurrence patient? You told one patient came back with recurrence. You again did surgery or something else?
We have done surgery.
Did you tracheostomy in this patient?
For one patient, we have done, sir. Actually, it is contraindicated sir, due to seeding of the disease in trachea and bronchi. But patient presented with stridor, we have done for one patient, sir. I have shown video of that patient on the post-operative. She is fine, sir. Now.
Okay.
Did you give only intralesional or both systemic and intralesional?
Intravenous also given, ma'am.
Okay. Maximum dose you can give? I mean, in the sense, how many times you can repeat?
One dose.
No.
I have
you can
one
repeat.
dose we have given to the patient, ma'am. It recovered.
No, it will resolve immediately, but again it will come back.
Recurrence.
Recurrence, we need to repeat intralesionally as well as systemic. I think as medical oncologists, you should do it so that they'll take care of whatever the complication the drug will give. And we can go with the medical, intralesional. Okay. And what other adjuvant therapy you can give for this? If this fails, what other therapy can be?
Other modalities of treatment.
Yes, the fourth then.
Interferon therapy also we can give now. But the complication. Hello? Can you hear me, sir?
Okay then.
Okay, yeah. Is the last one, huh? Is it over?
Yes, sir. Yes, sir. She is the last one. Sir, in the entire session, started from 17 number till 29. 3 are absent.
21, 22, 24.
22. Yes, sir. 21, 22, 24 refused to present.
Okay.
Others, 2 people extended their time, sir. 18 and 5. In the first session, 3 people were absent. All the 6 people who are absent in the entire case series, they will not be given certificates.
Okay.
Thank you, Ravi sir and
Yes,
Bharati
thank you, sir.
madam, for accepting our request for judgment. Thank you so much once again.
Okay.
Thank you. Thank you.
Sir, can you send
Thank
the
you.
marks tomorrow? No, it's
Yeah,
already
yeah.
late.
Sir. Yeah, you
Tomorrow
can.
morning I'll send.
Yeah, please, sir. Please, sir. Through WhatsApp,
Okay,
you can.
thank you.
Yeah.
Thank you so much.
Okay.
Thank you, sir. Thank you, madam. Thank you, sir.
Thank you, Deepti.
Thank you,
Bye.
Deepti madam and